Good morning and welcome to day one of the 2020 Oregon Housing Conference, virtual and online for the whole month of December. I'm Jason Renaud, coordinator of the conference. This is the first year that the Oregon Housing Conference has been entirely online, and our subject, COVID and homelessness, makes us acutely aware of how important it is for us to both not meet together and as a conventional conference interested in public housing, and also to maintain the quality of our professional knowledge and about these vital subjects. In the design of these 2 days, I wanted to both capture a snapshot of how the pandemic is affecting people who are homeless and unsheltered, both today and all the way back into February and March, as the public health officials were around the country were watching the virus migrate from China to hometown America. And I wanted to capture a frank and critical analysis of how 4 sample Western cities did and what they did and what they chose to invest in and what infrastructure was already available and what endured. As you watch these sessions, please recognize hindsight is 2020, and our public health leaders, both here and across the country, deserve our confidence and benefit of the doubt. We rely on their expertise, their experience, their professional relationships, their resilience, and their leadership. It's easy here at the end of 2020 to quickly look back and find fault, but that's not our intention today, and we won't learn from focusing on shortcomings. I selected 4 cities in the 9th Circuit Court decision on Martin versus Boise. They are Las Vegas, Los Angeles, Phoenix, and Portland. And I did that in part because each have a different approach toward managing homelessness, both as far as social services and healthcare, and each community is proud of its public health services. You'll hear today about Phoenix and Portland, 2 Western cities with very different local politics, economic structure, social strata, and racial consciousness. We'll hear our day 1 keynote at about 1 p.m. today. She's Dr. Margot Kushel, and she'll talk about how these and other comparable cities have thought about COVID and people who are homeless and unsheltered in her talk, Homelessness and COVID, a crisis upon a crisis. Now, continuing education credit for the Oregon Housing Conference comes through the National Association of Social Workers of Oregon. We'll certify 1 or both days for blocks of 6 hours each, 12 credits of clinical continuing education credit. Now note, you do not need to watch this conference in real time. Everything is recorded and will be available to you at any time during the month of December. On about December 5, a few days after the conference is over, I will send everyone who is registered for the conference an online form to complete for continuing education credit. Of course, if you do not need continuing education credit, you do not need to regard this form. But the form must be fully completed and submitted by December 31st in order to receive continuing education credit. On completion of that form, you'll be sent a PDF certification document via email, which shows that you attended 1 or both of the days of the conference, and you can send that document to your licensing body in your state. I want to thank the sponsors of this conference who made this possible. These are healthcare and service organizations which recognize and appreciate the value and potency of an independent and interdisciplinary dialogue about these crucial, timely, and complex issues. They are New Narrative, formerly Lukdorf, the Ganapati Fund, Aetna, Cascadia Behavioral Health Care, the Oregon Public Health Division, Regents Blue Cross Blue Shield of Oregon, the Oregon Health Authority and the Oregon State Hospital, Central City Concern, Care Oregon, the Oregon Community Foundation, Kaiser Permanente, Samaritan Health Services in the Willamette Valley, Multnomah County, Telecare, and Washington County. I'd also like to thank our partners, the Mental Health Addiction Certification Board of Oregon, the Fourth Dimension Recovery Centers, and the Oregon Council for Behavioral Health. Now today, our special guest is our keynote speaker, Margot Kushel. Let me speak a little bit about her. Dr. Margot Kushel, MD, is a professor of medicine in the Division of General Hospital Medicine at Zuckerberg San Francisco General Hospital and Trauma Center. And she is also the director of the University of California at San Francisco Center for Vulnerable Populations. Margot's research focuses on reducing the burden of homelessness on health through examining efforts to prevent and end homelessness and the mitigating effects of housing instability on healthcare outcomes. She uses a variety of research methodologies with an aim toward informing the development of programs and policies to end homelessness via the understanding of the complex interactions between health and housing. And she has a particular interest in homelessness in older adults and homelessness with medically complicated individuals. Dr. Kushel will speak for about 30 minutes, and then she will be available, and that will be live on December 1. And she'll be able to take your questions today, and you can ask questions in the chat forum online or by sending email messages, and I'll say that in a minute. If you're seeing this after December 1st, you're seeing a recording of the conference, and Dr. Kushel will not be able to take your question. Now, if you do want to ask a question, you can put it in the chat during the talk, or you can email it to me before or during the talk at coordinator@olmhc.org. That's coordinator@olmhc.org. Now, when we're through with the keynote and questions, we'll continue with our afternoon session about my hometown, Portland, Oregon. So please stand by and we'll get started shortly.
Hello, everyone. I know it's difficult times and that we're joining all virtually, but this is an important conversation. My name is Carlos Garcia. I am a city council member in Phoenix, Arizona for District 8. And I'm happy to have this conversation today. I know it's different because of COVID, but it's important because of COVID. In Phoenix, like across the country, we've been trying to figure out how to respond to COVID alongside with the long-term issue of people without shelter. And so to be able to have this conversation at this time is really important for us, and more important, to be able to share with each other solutions and ways and best practices that we can all share. Just to let you, just to tell you a little bit about myself, I grew up in Tucson, which is about an hour and a half south of Phoenix. I grew up undocumented with a single mother. And so I feel like I'm one of those elected officials that gets to have these conversations alongside the life experiences that I and my family have had. When I say I grew up undocumented, I was fortunate enough to gain my documents as a teenager, but my family didn't have the same fortune. I've had 6 people in my family go through deportation proceedings, 5 of which were deported. Growing up in a poor, majority people of color neighborhood, it was the common. Alongside poverty, obviously saw friends of mine lost to violence, some of them lost to incarceration. And so my path to being a council person is not the one that folks usually take. It's not something I thought of as a kid or even as a young adult that I would be here as a council member for the 5th largest city. It's something that's come about because of consequences and decisions that bodies like the Phoenix City Council, the state legislature, and the federal government have made, have actually forced myself, my family, and my community to organize and come into places like this to fix things. Now, the reason I tell you that story is because I think as we have these conversations, we need to remember a couple of things. And one of the main ones is to always look for those most impacted for the solutions. It's important for us to remember to include those that are most impacted, those without shelter, those that have been impacted by COVID in the solutions and in the policies that we're moving forward. Now, in Phoenix, like in most other places, we didn't know the COVID was coming. And we also didn't take into account that the CARES Act funding was coming. And I think one of the biggest lessons I've had in the last, 8 months or so, and it's a regret, it's not just a lesson, is that we didn't have that wish list. Obviously, none of us knew CARES Act funding was coming. And when it did come, we had to scramble to figure out what was the best thing. And again, that's here in Phoenix. Some of you all might have already had that wish list. And again, lesson learned for those of us that don't have it, we should always keep somewhere in a drawer a list of things that we could do to make sure we can help people the way we really want to in case a situation like this happens. Small story that happened to us during COVID. Early on, it was pre-knowing CARES Act funding or any of that was happening, someone donated 100 laptops to our office. A majority of public housing in the city of Phoenix sits in District 8. And so we felt we know exactly what to do. We're going to, take these laptops and we're going to send them over to our public housing. And to our surprise and a little bit of embarrassment for myself, once we gave those laptops, some of the folks, and I thank them for their honesty, told us, well, these are great, but they might as well be paperweights because there is no Wi-Fi in our public housing. Now, with that embarrassment, I didn't know what to do with it. I didn't know if at any moment we were going to be able to bring Wi-Fi. And so we walked away thinking, obviously, that's something we're going to write down in our list. And if we ever get an opportunity, we're going to try to fix this situation. Soon after CARES Act funds come in, obviously, it's one of the first things we jump on. But then we had another decision. We had a decision to address the immediate needs and try to get those students that were now studying from home, those parents or the family members who were trying to work from home, or those people that needed to do their healthcare visits at home. Do we get them laptops and Wi-Fi spots, which is what we ended up doing as soon as possible so they could address these needs? Or do we try to actually create infrastructure and create fiber to make sure that this is solved long term? Now, like I said, we ended up doing the hotspots, and I'm really grateful, and it's one of the highlights of being in office so far is to be able to give every school-age child in public housing a free laptop and Wi-Fi paid for a hotspot paid for 2 years. And we're grateful, and it's been amazing. Folks are, doing their schoolwork, their healthcare, they're taking care of themselves. But what would it have looked like if we would have had the plan to create permanent infrastructure? If we would have been able to finally get this money and we would have had things dialed up to make sure that fiber was present, and from here on out, anyone in public housing would have Wi-Fi. And I say that to acknowledge both a great thing we did and something we could have done better. And so this season of COVID, this epidemic has taught us many things. And it's pushed us to think of ways to support people that we hadn't thought about before. Very important, especially in a place like Phoenix, who's traditionally been a red state. After this week, I probably can't say that anymore, but at least has that red legacy where the bootstraps ideology has taken over, and we've dismantled and defunded any sort of public welfare or social net that we know is needed to be able to support, especially people who've been excluded, majority people of color, people who've been criminalized, poor people. And so as this frame has taken I think COVID allowed us to think about what are the things that we can do to make sure that that comes back. And when we talk about housing, we all know housing first. We all know taking away barriers, being able to support people with their basic needs is the way that we need to handle things in order for them to be successful and do what they need to do. And a lot of times it's been really hard because we're losing in these frames. And I think COVID has allowed us to see the faults in our society, to see the faults in what we have and haven't done for people. And so I'll end with some positivity. I think the framing around COVID in the sense of trust science or look at the facts as we reopen, as we do other things, hopefully can expand to the work that we're doing on housing and to support people without shelter. I think we have an ability now to take risk and to continue that frame of saying, trust the facts. We know if people's needs are taken care of, they're going to be better off. We know what the solutions are. I hope we can, through this conference and in other spaces, continue to share success stories of both how CARES Act funds were used. You know, some of the stuff we've done here in Phoenix has been great. Some of it has not. Some of us have fallen into our traditional enforcement or trying to push people away and do some of that. But we've also had some great successes where we've been able to pay for transitional housing. We were able to help an organization recently, US Vets, who was getting evicted from their shelter. And we were actually to partner with the city and purchase an entire hotel where they will now have a permanent home. And so all those lessons, I hope we bring them together. We have an opportunity to shift from the fear before, be able to take risks, be able to share with each other, and not saying we're going to solve the issues we're talking about, particularly people without shelter, but we can do it in the right way in this amazing time that because of COVID, we're able to merge the science, the facts, the things we know will work with the humanity and respect that we've learned to support each other and get through this pandemic. Again, thank you all so much for taking part in this conference. Would have loved to have seen everybody in Oregon, but this is the next best thing. Looking forward to some of the presentations from some of our folks from Arizona. I know we have people there joining from the county, from Maricopa County. We'll have people there presenting from the Andre House, an amazing organization here in Phoenix, and some folks who've been doing some amazing reporting from the Arizona Republic. Hope you have a great conference, and thank you for listening to us. Hasta luego from Phoenix, Arizona. This was Carlos Garcia, Council Member for District 8.
Hi, everyone. My name is Jessica Boehm. I am a reporter at the Arizona Republic in Phoenix. I actually cover housing instability and homelessness full time. I have been with the paper for 6 years, but I just started this new beat somewhat recently, though homelessness and affordable housing have always been big passions of mine and major coverage points of mine. I am a native Arizonan, but I have been to Oregon many times and wish I could be there now with all of you. But I suppose the world is keeping all of us apart right now, and we will learn to live with that. I'm hoping today to give you a brief overview of the state of homelessness in Maricopa County, which is our largest county in Arizona. It is where Phoenix and all of our major suburbs are. And when I say suburbs, I'm talking about 10 cities that range in size from about 150,000 to 500,000. So we're a pretty large area. We're the fourth largest county in the country and the fifth largest city in the country with Phoenix. So I'm hopeful that I can give you an overview of our situation with homelessness and also walk you through how we responded to COVID-19 in that population. So if you'll bear with me for a second, I'm going to share my screen and we'll get going. I'll go ahead and make my face a little bit bigger so you can still see me as we're going through this. But awesome. Okay, so let's get going. So let's talk about where we were at the start of 2020 before we knew COVID-19 was about to change all of our lives for a long time. When we did our point in time count in January, which is of course not perfect and likely an undercount, we found 7,400 people experiencing homelessness in our county. Now, if you look back the last 5 years, you can see that our overall homeless numbers have been ticking upward for 6 years now. Now, equally concerning, if you look at the bottom part of that graph, the orange part, you can see that our unsheltered numbers have been increasing significantly at an even higher amount than the total homeless population. And this is really because of a number of factors. First of all, we are on the short side of shelter beds in Metro Phoenix. And I'm going to say Metro Phoenix and Maricopa County interchangeably. They're basically the same thing, but just so you know. So the numbers that you're looking at here, I will say these are just emergency shelter beds. So obviously there are other types of shelter that are not showing up on this list that we do have access to. But we still have what most providers would see as a shortage of shelter beds in our community. So we have a total of a little over 1,700 emergency shelter beds. 110 of those are reserved for medical patients. 731 of them are family shelter. Another 200 are things like domestic violence, youth, specialized shelters for specialized populations. And then we have 708 single adult beds, which I think are probably the best thing to look at because those are the beds that you can get regardless of your circumstance. And when you see that we have 708 single adult beds and, a total homeless population of 7,400, which we know is probably an undercount, you can see why we're seeing such a large number of unsheltered population. So just for your background, 470 of our 708 single adult beds are at a single shelter, our largest shelter in the state. That is the Central Arizona Shelter Services Shelter, or CAS as we call it. I'll probably slip and say that at some point, so just so you know my acronyms. And that is part of the Human Services Campus, which is a congregation of about 20 nonprofits just south of downtown Phoenix that offer services to our homeless population. So as I noted, we have an undersupply of emergency shelter beds generally. And there have been pushes in recent years for additional shelter beds. Those have been mostly met with a lot of opposition. There's currently a zoning request going through our city council to double the number of emergency shelter beds that we could have at the CAS campus. And that has been met with a lot of pushback. A lot of people believe that it's a better situation to have smaller shelters across the region than to congregate such a large population in one neighborhood. I think most people actually do agree with that, but at this point, we are not seeing many neighborhoods like putting their hand up and saying that they're, welcoming to this population in their neighborhood. So basically, what we're seeing is we have communities who don't want more shelter beds in existing shelters, and we also don't want more shelters generally. We say we do, but when it comes to actually citing a location, it doesn't get very far. So we really, pre-COVID, are having this, conversation in our region about what shelter beds should look like. So that's why we're seeing, or part of the reason why we're seeing such a large number of unsheltered individuals in our population. We've also gotten rid of overflow shelter at CAS or near CAS. So, a few years ago, we had an additional 200 to 300 people with a roof over their head, and we don't have that anymore. So this is, and I'm not going to read through all of these, but if you would like to, you're welcome to. But this is just a little bit of a background as to why I think we're seeing more homelessness generally, not just unsheltered, but you also saw that full bar graph continue to tick up over the last couple of years. So we, in Phoenix, in every city in the country, we've always had people experiencing homelessness in our community. But that was a pretty contained population for a long time. It was typically people who were dealing with pretty intense situations regarding addiction, mental health, the criminal justice system, or other very specific needs. What we're seeing now is more economic factors playing a role in why people are becoming homeless. And that's really new for us in Arizona. Metro Phoenix has always kind of been like this mecca of affordability. You see affordable housing crises in LA and Seattle, all over the East Coast. We've never seen that before. In fact, people moved to Arizona often because they could afford it. And so that really offered a decent quality of life for people at all income brackets for a long time. But in the last several years, we've seen record prices in both our housing prices and rental prices, and you're really not finding reprieve anywhere. So all of this is before COVID-19. We were seeing rents climb at unprecedented rates and really just creating a big problem in our housing market, something that we've seen, a phenomenon we've seen that I think will only continue after COVID, is we're seeing a lot of people move from more expensive cities like Houston and LA to Phoenix and be able to keep their jobs working remotely. So they're bringing their Houston and LA wages into Phoenix, where our wages are so much lower and have definitely not increased with the housing market. And so it's pricing out a lot of people who were already living here. So, I'm giving you a broad overview of our housing market. I know you're here to talk about homelessness, but I think it's important to bring up because I really do believe that we are seeing more and more people pushed out of housing because of these economic factors. When people in our most vulnerable people or our lowest income families can't find housing that they can afford, they end up moving into places that they can afford. And then they miss rent and then they get evicted. And you can see we have one of the highest housing loss rates in the country in Maricopa County. And when you have an eviction on your record, it's just very hard to ever find a place to rent again. So, while all of these housing market things are part of a bigger issue, they really are causing a lot of homelessness in our community. So this is just kind of a background for you to understand where we were before COVID. Now I'd like to go back to March, the earliest days of March, when we started to realize that COVID was going to be a part of our life for probably a much longer time than any of us wish. So I'm a journalist, and that means that I'm not in the business of giving praise very often. But I will say I'm happy to praise the work that our homeless services providers and shelter providers did in those earliest days of COVID-19, because the immediate reaction by them, I think, without a doubt, saved lives in our sheltered homeless population, especially. So, when we first realized COVID-19's impact, people in these shelters, especially the really large one, Cass, that has 470 beds, realized we can't have 470 people congregating in a few rooms. That's, not going to be a healthy situation. And what seemed like almost overnight, really, the Human Services campus in Cass were able to repurpose buildings on their campus, things like a day room or a cafeteria, into temporary shelter. And they partnered with their healthcare for the homeless provider to do basically medical evaluations of everyone on the campus, everyone who was staying in the shelter. And that really allowed them to create a system of ranking to see who was the most high risk. And people that fell into those like super high risk categories, either because of age or health risk, were then quarantined in special areas like the day room and the cafeteria, so that they were away from the general population until they could figure out what they were going to do long term. At the same time, the Healthcare for the Homeless provider Circle the City put up medical tents in the parking lot. And that was great in those beginning days when we didn't know, does everybody on the campus have COVID? Does nobody? It was all very confusing in those early days. That allowed there to be space for people to wait while they were waiting for their test results. So if you had symptoms or if you're around someone who was known to be positive, you had a place to go where you could quarantine and not get anyone else sick. Those, again, seem to go up overnight. And I will say also, all of the shelters in the Valley that I know of, the Valley is another name for Maricopa County. I'm sorry, we've got a lot of them. But all of the shelters in our area really implemented mask requirements and social distancing well before any of our government leaders put anything into effect. So there was this immediate, I think, response and realization by our service providers that if they didn't work very quickly, there could be a really tragic situation. And obviously, we all saw projections of the number of people who could die of this disease in the homeless population. And, thankfully, we have not seen that happen in Maricopa County. So I walked you through what happened in the immediate days. Over time, we've kind of changed the model. So those medical tents I told you about that the healthcare provider was offering, those worked really well at first in March and April, but I know you guys are from Oregon and have your own weather challenges, but we really have challenges with our summers, and it was extremely hot, and those were just no longer effective in the heat. So luckily, our county government provided funding for Circle the City to rent out a hotel that had closed and basically offer like full service healthcare to anyone who tested positive at that location. So it really worked a twofold. It gave them a place to stay so they weren't getting anyone else sick, but it also, provided easy access for the medical providers to make sure they were taking care of those people who did test positive for COVID-19. At the same time, they kind of outgrew the day room and cafeteria areas for our vulnerable people. And both the city and the county provided funding for organizations to start housing people in other hotels. This hotel model became really popular really fast, and it's been pretty effective. So CAS has now rented out 100 rooms in a hotel in North Phoenix. It's actually, part of it is still used as a regular hotel, and the other part is rented out for seniors experiencing homelessness. I've been out there. It's really been impressive to see the additional attention people get in a more one-on-one setting. And I mean, also just to go from either being on the street or living in a congregate shelter setting to having your own bed and bathroom, like it's, everyone I've talked to has been very happy with that. And it's something that I think people hope could maybe continue long-term. We've also started other regional hotel programs to get more of this idea of regionalization. Let's not congregate everybody in downtown Phoenix. So the county has also provided, funding to rent anywhere from 25 to 50 rooms in other parts of Maricopa County as well. And that's really, I think, been the most strategic and effective thing that the providers have done for our sheltered population, because obviously there's a big risk when being sheltered is great and obviously important for long-term health and services purposes, but it's also really hard when you have hundreds of people in one room and you have a virus going around that spreads like wildfire. So the utilization of regional hotels and shelter programs, I think, was really effective. So now we go to our unsheltered population, which has its own set of, things that make it both easier and more difficult during COVID. Obviously, they weren't living inside. We know now that being outside is better for, not transmitting the disease. But being outside also can make your other health conditions worse. And that makes you a higher risk for more serious side effects of COVID-19. So this is specific to one part of the unsheltered population. So we know that the CDC said pretty early on that we shouldn't break up encampments because that would maybe cause people experiencing homelessness to then further disperse into other parts of the city and cause more issues with spreading the disease or the virus. So our largest encampment is on the streets surrounding the Human Services campus where the largest shelter is. There's anywhere from 300 to 500 people sleeping in tents outside the shelter every night. So Maricopa County decided to use 3 vacant parking lots near the campus, just walking distance from it, and basically draw these 12-foot by 12-foot squares on the pavement and have the people who were sleeping right in that area move on to the parking lot. And hopefully those markers would encourage people to social distance. There were also bathrooms and water facilities brought in, which they didn't have living on the street prior to that. So I would say there were mixed reviews on this. I go down there quite often. They're still open now. They're supposed to be there till the end of the year. And I've talked to some people who think it's great. They have toilet facilities now. They don't have, police officers waking them up every morning and threatening them with trespassing tickets. There are other people who don't like it that much, who feel like it's like a prison situation. There are, gates around it and security. And that's got good and bad. But the biggest issue, and one of the things that I think people were most concerned about were the heat. This, as you can see in that photo, there was no shade. We spent a lot of our summer above 110 degrees. And, it did take a toll on that population. We unfortunately did see heat deaths in this community. That's not because of the safe outdoor space. That likely would have happened regardless, just because it does every year. And that, I think the visual though of this, it required more people to think about how hard it is to be in the heat and be homeless. And so it was a little controversial, but that is what our policymakers decided to do with part of our unsheltered population. People who were living unsheltered in other areas, either other encampments or just on their own throughout Maricopa County. There were programs from the healthcare provider to try to go out to those areas to educate people on the virus, to get them tested if they had symptoms, and to make sure that they knew about, mask and social distancing requirements as well. So there were several other things that the city and state and county spent money on during this time to help the homeless population through COVID-19. In addition to all the things I just mentioned, like the hotel programs, which were funded with CARES money, we had some other things as well. The city of Phoenix has a convention center. Obviously, conventions didn't really go on this summer. So they were able to take their convention hall and kind of turn it into a respite. So, obviously that's a very large space. So people were able to physically distance, but be inside during those harshest days of the summer. We also had all of those government entities provide CARES funding directly to food banks and other nonprofits for things like PPE, and physical supplies, especially with the food bank. I mean, we had more people signing up to receive food than possibly ever before. The city of Phoenix also put more money into permanent supportive housing, rapid rehousing, and voucher programs with the hope that any of these people who go and stay in the hotels for temporary shelter won't discharge back to the street. So hopefully the people who are staying in those hotel programs now will have a safe place to live after this. That's the hope of that money. And then this isn't directly related to homelessness, but it is related to homelessness prevention, I believe. We had, well over $50 million going towards rental and mortgage assistance for people who couldn't make their rent or mortgage, which I think probably prevented a lot of homelessness. It probably isn't enough, however, and I think we're all a little concerned about what happens next in Maricopa County and throughout the country with evictions, and if that translates to more homelessness. So this is, I'm going to move my little face down here for a second. This is something that I think a lot of people think that a lot of good has come out of the city, county, and state funding as it relates to the homeless population and COVID-19. But the one thing I hear about missed opportunity is I think a lot of people hoped that there was a way to spend some of this money to get some long-term solutions. So as you all know, the CARES Act funding, which is most of the funding I was just discussing, expires at the end of the year. And we all know that more bad could be coming. Evictions are likely to start up again with haste in January, and that will translate to more homelessness. So a lot of providers were really trying to push the city, the state, the county to invest in infrastructure that they could, yes, use now for COVID-19, but also use moving forward. So like an example, instead of, giving a provider $1 million to rent the hotel for seniors, was there a way that they could have used that money to purchase a hotel that they could use now and use after this? And we still have a month or so left, and maybe some of those purchases will come. But I think that's one thing that's kind of been, it was a missed opportunity when you had this much money for probably the first time ever coming in this arena. There is one good example, though. The city of Phoenix actually a few months ago learned that our U.S. Vets program, which houses 200 veterans, the landlord of the property they were renting to house these veterans decided to almost double their rent. And again, another consequence of the housing market I was discussing. And they didn't know where they were going to go or where they were going to house these veterans. And so the city of Phoenix actually stepped in and gave them $10.5 million to purchase a facility that they, yes, can use now for COVID-19 reasons, but also can have moving forward, and they'll no longer be, at the whim of the rental market, and they'll be able to house veterans indefinitely, hopefully. So that, I think, is an example of what a lot of people wished would have happened more. And then I'll move myself back up here. There's a few things that I've taken away from COVID-19 in the homeless population. The most important, I think, is that working together works, which sounds silly, but one of the most frustrating things covering, human services agencies and nonprofits and organizations is there are so many people who want to do good, but there's so many silos between those people sometimes. And a lot of times everyone's working in, 100 different directions trying to reach the same goal, which can be frustrating as an outsider to observe. And those silos broke down instantly when this happened. It was just clear that everybody realized that there was going to be a tragedy if they did not work together. And that collaboration it was impressive to see, and I hope it continues moving forward. I think it's the only way that we're going to have sustainable solutions to homelessness, and I really hope that everybody takes that lesson that they learned and realize that it's better to work together than to work alone. The other thing is, I know nobody likes to talk about how expensive solving homelessness is, but it is, and funding is important. And I think that this last year really proved that homelessness is solvable if we have the money to solve it. And I mean, you just look at it, we're in the middle of a pandemic, and right now we are sheltering more people than we ever have because of the hotel programs. We are housing more people because there's more assistance in the housing programs. And we kept people safe and healthy during a global pandemic. I think that really goes to show you that if you put adequate resources towards something, it's not only, possible, but it's not even that difficult to solve this problem. You just need the money and you need people working together. And so I really hope that, providers can leverage this example to prove to their policymakers just how important money is in this solution finding. It's essential. And I think the cost is pretty low when the result is people being housed and ultimately saving lives. And these other two things kind of go hand in hand, but I do think, as horrible as this situation has been, it has forced people in Maricopa County to realize that we have a real housing problem. And we absolutely do. And I think people are now realizing that it's not just like, oh yeah, housing prices are going up. It's actually a crisis, and that we need to find a way to add more housing to our community that people can afford. And I think I can see it. I am on a bunch of I attend different task force meetings and stuff, and people who never talked about affordable housing are talking about affordable housing. And that's one really great thing to come out of this. And then, this is probably very apparent to all of you, but this pandemic has just showed how weak our social safety net is, I think, in every state, but Arizona is definitely no exception. We've had more people apply for unemployment and rental assistance and other kind of government assistance than, probably ever before. And it really shows that we need to do a better job of making sure that people, have a safety net when these kinds of things happen. Hopefully we won't have another global pandemic in our lifetime, but we will have other emergencies. And I hope that this allows us to think more creatively about how to be sustainable. So that is my spiel. I am really excited to listen to the rest of the conference. I hope this was helpful to you all. As I mentioned, I am now covering homelessness and housing insecurity full time. I'm very curious about how the rest of the West is handling this problem. So please feel free to reach out to me either by email or on Twitter. I'm happy to make your acquaintance, even if from a distance. So have a great rest of your conference, and thanks for inviting me to participate.
Whether you are recovering from an injury or illness or looking for support and guidance to live a healthier life, Samaritan Health Services wants to be a part of your journey. Together, we can achieve wellness, strength, hope, and joy. Find inspiration to live your best life in stories of triumph, resilience, and determination at samhealth.org/together. Samaritan Health Services, building healthier communities together.
If you remember one thing today, remember this. You matter. And because you matter, the world is better when you're healthy. That's why Care Oregon helps our members get the care they need from the Oregon Health Plan. And lots of good things beyond health care. When you're stronger, you make everyone around you stronger too. That's the Care Oregon effect. Learn how to apply at careoregon.org/OHP.
It's very hard for people to take care of their mental health needs, physical needs, if all you're doing every day is trying to find a safe place to sleep. We're all in this together. And the struggles that some people have, that could be anybody. That could be, me in 2 years. I don't know.
The state of mental health in the country right now is very, very challenging. There's enormous need from many individuals, and oftentimes there's limited ability to access or receive those services.
Historically, whole health care has been, you've got your primary care provider, you've got your mental health provider, you've got maybe your addiction specialists, and they're all sort of doing their own thing independently with very little communication amongst them. But whole health care for us now at Cascadia is that we're bringing all these entities together under one roof. And that's really exciting because now I get to work for a team of diverse professionals with various skill sets, knowledge, experiences, and we get to all put our brains together to really work on finding the best solutions for patients and getting the best outcomes.
So if we can address health from the behavioral health perspective first and foremost, and then add on substance use treatment, physical health treatment, housing, employment, social factors, wellness, you put all of those together, and that really wraps around someone creating a sense of whole health. So we've followed 900 individuals who have received behavioral health services who also are enrolled in our primary care as well. We found that over 80% of those individuals had not seen a primary care doctor in over 2.5 years. Over a year and a half time, we found that we reduced their utilization of the emergency department by 18% and their inpatient medical admissions by 23%. I have never seen results like that in my career, and it is a testament to an approach that can work really well to improve people's lives. It would be ideal to have more centers like the Garlington Center, a space where people feel comfortable, both clients and our colleagues, a space that is respectful and safe, and a space that promotes this approach of providing whole health care where individuals can get a variety of services that they need to improve the quality of their lives. I could not be more excited for the creation of Garlington because it creates the first step towards a model of care that hopefully we can deliver here in Portland. We always must have support from our community in order to create these centers that really serve many important goals in our community. So we really rely on the generosity of our donors to achieve that, and we're so grateful that people believe in the work we're doing and stand with us in helping us move that forward and create places like Garlington.
Hi, I'm Dan Field, Executive Director of Community Health and External Affairs at Kaiser Permanente Northwest.
Hola, I'm Rocio Acosta, and I'm a bilingual engagement specialist with Kaiser Permanente.
Hello, I'm Tracy Dan and Grace, Director of Community Health at Kaiser Permanente.
Hi, I'm Aaron Waters, and I'm an Equity, Inclusion, and Diversity Consultant for Kaiser Permanente.
Hello there, I'm Ron Scholes, and I manage the Northwest Employee Community Engagement Initiatives.
We're sorry we can't be together in person.
But we applaud you in your efforts in working in innovative ways to serve our community members in need of vital services.
Congratulations on your accomplishments.
And thank you for all you're doing to support our most vulnerable community members in this unprecedented time.
We miss being able to gather together
And celebrate the great work you're doing in the communities where we live, work, learn, and play.
But we are navigating these uncertain times together.
And together we will become better equipped for a new normal.
We are resilient.
We will persevere.
And we will once again thrive.
Yes.
Good afternoon. I'm Bruce Liggett, the Human Services Director for Maricopa County. I'm really pleased to have been invited to present at the Oregon Housing Conference. I, like all the other speakers, absolutely wish this could be in person. I do best when I can see the people I'm speaking to and we have a little interaction and dialogue and chance for questions. But I still think it's really important to be able to go over, and I'm looking forward to listening to the other presenters during the conference. So let me first start by providing some background in terms of Maricopa County, Arizona. Let me give you a little background, first of all, in terms of Maricopa County. It's a very large and diverse county. We've got over 4.5 million people. It's been for many years the fastest growing county in the United States. We have 25 cities and towns, some small, some very large, the largest being Phoenix, with a population of 1.7 million people. Since it's the biggest city, we've got great relationships with them and coordinate our activities around our homeless planning extensively with the city. A little more background perhaps on the Maricopa County Human Services Department. I've been with the county now for 7 years, and it's a very unique array and arrangement of services in terms of Maricopa County. We have early education, which is Head Start primarily, community services, which is really our anti-poverty arm, our community action programs, where we provide rent assistance, mortgage assistance, and primarily utility assistance. There's been a huge demand and need for those during the pandemic. Our Housing and Community Development Division is responsible for affordable housing, primarily in some of the smaller and medium-sized communities. Some of the larger cities get their own direct funding. But with funding from HUD, we're able to do much housing development, as well as all of our homeless work. Workforce development, we operate workforce services throughout the county, except the city of Phoenix has their own. So again, we work closely with the city to make sure we have regional approaches to our workforce services. And finally, senior and adult services, where countywide we provide case management to individuals who need home and community-based services to retain their dignity and be able to stay in their homes safely. Some overarching themes and initiatives that are part of the department and really kind of in the context for how we do our work. First of all, there's quite an array of responsibilities for human services in Maricopa County. The federal government has a role primarily as a funder. The state also provides funding, but the state operates the public assistance programs, the SNAP, TANF, unemployment insurance, child support enforcement. Counties fill in the gaps, receive funding from the federal and state to administer the program, and Maricopa, being the largest county in Arizona, works with a lot of local communities who may also have their own human service departments. Given this kind of shared responsibility, sometimes could create gaps, sometimes can require more coordination, but the need is overwhelming. None of our programs are in scope or scale with the need. So the only way we can really address all of the needs of the people that we're trying to serve is through partnerships. We have robust partnerships with 130, these are formal partnerships, organizations, nonprofits, public entities, faith-based organizations. So we do our work by partnering. Within the department, we have a lot of cross-generational and program initiatives. So we work, for example, our workforce program tries to help Head Start families get jobs that they may need. Our workforce program also works with the homeless population. Our community services program provides utility assistance for seniors. So we've really tried to integrate the various programs and all of the narrow funding streams that create so many barriers for people. As part of that, we've got a major emphasis on 2-generational approaches, trauma-informed care, and whole person, really looking at the whole person, trying to move away from the narrow scope of services that are available to people and provide comprehensive services that meets the family's need. We do a lot of collaboration with other funders and have on homeless. In fact, our work with a funders collaborative with the state, the city of Phoenix, and United Way 3 or 4 years ago resulted in a major depopulation of a parking lot that was then used for people with no services available. And we were able to get hundreds of people into housing as part of a collaboration. So you can see this is how we do our work. We work with others to try to meet the need. The resources are limited. And then what hit us all was the COVID pandemic. So I'm really going to focus today on the homeless challenges and our responses to them. Many of these are going to be familiar to you. We're doing some things I think that are unique, but largely what we're doing is what everybody's been doing and scrambling for the past 8 or 9 months to put into place what's necessary to really provide for safe, secure, health-related care for homeless individuals. So we've done best practice reviews and sharing, exchanging information with CDC, HUD, USICH, other states, other counties, and the cities. We try to stay on top of it. There's a lot of good information out there, and it's hard to keep up. Maricopa County's approach was through our emergency management system to combine public health, emergency management, and human services as a part of that as a unified command, sitting down at the table with all the entities to plan our actions. We've got a very good relationship with our public health department. It's been a challenge to kind of balance the urgency of the situation and collaborations. I think collaborations have suffered because as we received the CARES Act, the federal funding, and had urgent needs, whether it was for utility assistance, housing, homelessness, safe shelter, we had to respond immediately. And while we've tried to share information, we're not working as collaboratively as we used to. We're getting back on track there now, but I think that's been a really stressor for the system, a real challenge. We have relied extensively on regional providers. The healthcare for the homeless provider, here called Circle the City, engagement and mental health providers, an agency locally known as Community Bridges, and working with the Downtown Human Services Campus. Now, I should explain, the Human Services Campus was established about 15 years ago. There are 12 separate nonprofit entities that operate in that campus. It's the largest concentration of homeless individuals in the state. They provide services to 1,000 people every day in and around the Human Services Campus. Another approach we take is, as we think we learned something, whether it was a good experience or we learned not to do something else again, we try to share those protocols, lessons learned regionally. Biggest overall challenge has been so many unknowns. When we began this, there were a lot of estimates of how many people, homeless people, might be impacted, and those were huge ranges of responses we might need. I've said often, if I knew back in February and March what I knew now, things would move even better. Now the unknown is, when will this end? When is the end? If somebody at least would say this will be April 5th, we could plan around that. So we're really going along, trying to stay on top of the situation as best we can, but it's been a huge challenge for us. More specifically, let me go through some of our strategies for addressing homeless population who are at risk or have contracted COVID-19. The first thing we did is work in and around and with the Human Service Campus and the providers there to be able to put in protocols to screen, identify, and test individuals for the virus. Those protocols were put in place and shared with other shelters around the county. We provided tens of thousands of personal protective equipment, PPE, and informational materials to providers, how to identify symptoms, what to do if somebody is believed they've been exposed to coronavirus. Over the past 8 months, we've had leases with 6 different hotels for vulnerable and at-risk populations. These have been in Phoenix, as well as other parts of the Valley of the Sun, the county. Today, we only have 3 of those hotels. Some of them have continued to operate by cities themselves. So the number keeps changing. One specific hotel was leased for people who are positive, who are known to have the COVID virus, and for people who are under investigation, who may have been symptomatic, may have been tested, and need medical supervision, isolation, quarantine. So we've got a hotel that accommodates that, and that numbers have ranged. For a while, the number in that hotel was 20 or 30. About a month ago, maybe a little longer, it dipped down to 1 or 2 per night. And recently, we've been up as high again as 30, some nights 50. People don't stay there long. They stay there while they're quarantined or getting medical treatment. If their condition worsens, obviously they go to a hospital. We've established a triage line that was designed for hospitals. Not every homeless person is in contact with a mental health provider or with a shelter. So there are people in hospitals who are being treated who report that they're homeless. When they're ready for discharge, we have a triage line that hospitals or shelter providers can call to talk to somebody who's knowledgeable about what to do in certain circumstances. If people need to be transported to one of our vulnerable hotels or to our COVID hotel, transportation is provided. Early on, we knew that we had to address the large encampment of people in tents and outside of tents in and around downtown Phoenix, specifically around the Human Services Campus. So we implemented a voluntary test distancing site to provide a temporary, and we emphasize temporary, didn't know how temporary it would be at the beginning of the virus, a safe outdoor space. So there are 3 county lots that are being used, again in downtown Phoenix, close to the Human Service Campus, where we put in additional dumpsters. We've added toilets, hand washing stations, had to bring lighting, nighttime lighting into the situation, a large water station, and security. And those services can be used by people who are using the safe outdoor space or the tent lots, as well as other homeless people who may choose not to come into the tent lots. throughout the country, we've all had to reduce some of our shelter capacity. That became a real challenge during the intensely hot summers that we have here in Arizona. With temperatures exceeding 110 often. So we knew that we had to have additional facility, which we established. The city of Phoenix did a great job of providing daytime weather relief for people at their convention center. And then we had some smaller facilities where people could stay during the night. City of Phoenix coordinated transportation between these weather relief sites. And so we were able to provide weather relief for people. In fact, we had capacity still available during evening weather relief. So we're pleased that we were able to respond to that unique need since shelters weren't available there for as many people as they had been previously. What are our next steps? We're obviously continuing to actively monitor the situation, track what's going on, count the numbers, see the trends. To date, I'm pleased that there's been no data that's been available that the homeless population has been disproportionately impacted when compared to the general population in terms of the percent of positive cases within them. So our efforts have made a difference. We need to stay vigilant. We know the flu season has already started, and so that's going to put an extra strain on our system. Our goals, like many others, are to provide housing for people who we placed in hotels first. So I mentioned the 6 hotels we've established. A couple hundred people have been utilizing those hotels. They're older, they have medical conditions, they may be seniors. Those are the people who are our priority to not have to move back into the shelter, certainly not into the street. But the plan there is to try and find permanent housing for people who have been vulnerable and in our CARES-funded hotels. The next goal is for utilizing the hotels where we have some capacity. And as some of our numbers have dropped, we're retaining those hotels and we're going to use those for bridge or transitional housing for people. So we've got that capacity now and are developing plans to put people in through rapid rehousing or permanent supportive housing. Again, the ideal goal would be that nobody has to go back into a shelter that has been in a hotel temporarily. We also want to we're trying to utilize our funding that we have through Community Services Block Grant, Community Development Block Grant. Those funding sources have a little bit more life than does the CARES funding. Perhaps I should explain. Overall, we're estimating that these efforts this year, we will have spent about $12 million. And that is primarily from CARES Act funding, which, as you know, expires on December 30th. Some of the other funds that we received directly from HUD, Emergency Services Grant, for example, last in another year or two. So we're putting together a plan because the CARES money, the $12 million, runs out December 30th. The services we've been providing cannot run out December 30th. We're very hopeful that Congress will act and add additional money, not only for our homeless services, but for the preventive services. We know with the eviction moratorium, the CDC eviction moratorium ending December 30th, that there's going to be a huge impact on people who have been unable to pay their rent or utilities, and that the funds that we've used to assist are dwindling and ending. So we really do need congressional assistance in human services to continue the services for housing, homelessness, rent, and utility assistance. So putting together, we are actively working as we speak here in the end of November for what the plan will be to fund these programs beyond December 30th and how to sustain them and how to meet our goals of trying to provide housing for people who've been temporarily housed or need to be placed. So preparing for the vaccine is a big part of that work. We have all heard the positive news that the vaccine may be available in the next few months. The populations that will be a priority obviously will be first responders and healthcare professionals, people working in that field. We know that people involved in long-term care facilities will also be a priority, and so will the homeless. The homeless as a vulnerable population will be a priority in terms of rolling out the vaccine. When will it be here? How will we distribute it? All these things are going to be developed over the next month or two. So I guess in my long career in human services, one of the things I want to acknowledge is how privileged I've been to be able to work with the nonprofits and the cities and towns in Maricopa County to address homelessness. It's been an ongoing challenge. Homelessness has increased in this county over the years significantly, 18% in the last year. Unsheltered homelessness has increased, and yet we've all worked together, responded in a crisis situation, and provided services that have made a real difference to homeless people in this county. So the efforts have paid off and have made a difference. And we're going to try to build on those efforts for the future, take advantage of the short-term resources and build structures and systems that can be in place for people ongoing. So I really appreciate the time to be able to provide this overview to you of what we're doing in Maricopa County. The work that we do is in coordination with the City of Phoenix. We have a great partnership with them to address a really significant challenge. Our work is gratifying, as your work is. And so thank you for the opportunity to provide you an update on what's going on in Maricopa County and Phoenix, Arizona. Thank you.
For over 40 years, Central City Concern has helped thousands of people to find homes, to regain health and recovery, and to build economic stability and resilience. Every year, CCC works with over 13,000 people across several domains. We provide health care, inclusive of primary care, addictions care, mental health, that is really person-centered. We provide supportive employment, walking alongside people to help them get meaningful wage jobs. And we work with people to find housing that is safe and supportive and affordable.
I went from homelessness to homeowner in a matter of 10 years. I feel, my story does help others believe that they can do it too, because I did it and I didn't think I could do it. Some people have never had a job, or maybe it's been a very long time. And so we are able to offer more compassion and coaching, getting people ready to get into a more permanent full-time position.
Because of CCC, I was able to get my prison sentence suspended because they see me out here working and cleaning up the town. I'm 36 years old, been in recovery for 19 months and 9 days. Got 5 kids at home. CCC actually helped me change my life because I got a job that I'm able to work with the background that I have, and I'm able to feed my children, and got a nice place to live, roof over my head. The people here at CCC are like family to me, especially my bosses. And yeah, they help me out with my recovery.
CCC has all the resources, the tools to get your life back in order. My name is Ralph Fakoko Tase. I was born and raised in Samoa. I didn't really think about recovery because I try to get clean on my own. You know, when you're talking to yourself, when you're trying to do it by yourself and you're trying to do it alone, it never works. I would be nowhere where I'm at without the support and the programs that CC has. I'm talking about from Hooper to the recovery program, treatment, the medical field as well. I FaceTime my son every Saturday now. For a very long time, you know, that wasn't an option. I value things today. There's so much value in my life. You know, if I can do this, anybody can.
The impact CCC has is outstanding. The patients and the clients we can reach to, the things we can help provide to them, I think they come in not knowing what we can really do for them, and then when we're able to show them that, I think they're just beyond grateful. Our care teams provide a lot. A patient can come in and just as simple as just have a checkup, but if a patient comes in that's homeless, they need more medications because theirs got stolen or their IDs have been stolen, we definitely go above and beyond and go out of our way to try to find them the resources that they need.
We're each a piece of this puzzle. We're all equal and we all have a place. When we're all in this together, we create one beautiful CCC picture.
Thank you, CCC, for all the advantages that you guys gave me and helped me out. I got integrity in my work just because of that.
Thank you, Central City Concern, and all the mentors that helped me along my way to become a better person.
And thank you to Central City Concern.
Faftai Lava CCC.
Nearly 1 in 5 U.S. adults currently lives with a diagnosable mental health condition. Yet the dominant treatment model is still one size fits all, focusing mostly on people's symptoms rather than their needs, goals, and dreams. We believe everyone deserves to participate in the community without stigma or fear, to have a safe place to live, hold steady employment, and to build lasting friendships. We're here to create a new narrative for mental health, to move away from treating mental health conditions as problems that need fixing and toward a model that embraces what you want out of life. We are New Narrative. Originally founded as Lukedorf, New Narrative has been serving the Portland metro area for over 40 years. Our first site opened with the guiding thought that hope, compassion, and community were the key to mental wellness. We have since grown from a single site to an agency made up of outpatient clinics, residential treatment, peer programs, a transitional age youth program, supportive, transitional, and independent housing, homeless outreach, and housing navigation. We still believe that hope, compassion, and community are the keys to mental wellness, but we also know there are many ways to get there. We believe achieving meaningful impact requires us to think differently, see differently, and work differently. We are intentionally working to change a system that identifies people by their diagnosis into a system that values the person. A system that understands a diagnosis is something a person experiences, but isn't who they are. We're here to change the narrative on mental health services, to retire the term mental illness and focus on mental wellness, to stop containing and start embracing, to ensure that people seeking services can find a safe place to live, hold steady employment, and build lasting relationships. We believe the health of a community comes from the visibility of its people. We all deserve to be heard, seen, and recognized. It's your story. Live it your way.
Whether you are recovering from an injury or illness or looking for support and guidance to live a healthier life, Samaritan Health Services wants to be a part of your journey. Together, we can achieve wellness, strength, hope, and joy. Find inspiration to live your best life in stories of triumph, resilience, and determination at samhealth.org/together. Samaritan Health Services, building healthier communities together.
If you remember one thing today, remember this. You matter. And because you matter, the world is better when you're healthy. That's why Care Oregon helps our members get the care they need from the Oregon Health Plan. And lots of good things beyond health care. When you're stronger, you make everyone around you stronger too. That's the Care Oregon effect. Learn how to apply at careoregon.org/OHP.
It's very hard for people to take care of their mental health needs, physical needs, if all you're doing every day is trying to find a safe place to sleep. We're all in this together. And the struggles that some people have, that could be anybody. That could be, me in 2 years. I don't know.
The state of mental health in the country right now is very, very challenging. There's enormous need from many individuals, and oftentimes there's limited ability to access or receive those services.
Historically, whole health care has been, you've got your primary care provider, you've got your mental health provider, you've got maybe your addiction specialists, and they're all sort of doing their own thing independently with very little communication amongst them. But whole health care for us now at Cascadia is that we're bringing all these entities together under one roof. And that's really exciting because now I get to work for a team of diverse professionals with various skill sets, knowledge, experiences, and we get to all put our brains together to really work on finding the best solutions for patients and getting the best outcomes.
So if we can address health from the behavioral health perspective first and foremost, and then add on substance use treatment, physical health treatment, housing, employment, social factors, wellness, you put all of those together, and that really wraps around someone creating a sense of whole health. So we've followed 900 individuals who have received behavioral health services who also are enrolled in our primary care as well. We found that over 80% of those individuals had not seen a primary care doctor in over 2.5 years. Over a year and a half time, we found that we reduced their utilization of the emergency department by 18% and their inpatient medical admissions by 23%. I have never seen results like that in my career, and it is a testament to an approach that can work really well to improve people's lives. It would be ideal to have more centers like the Garlington Center, a space where people feel comfortable, both clients and our colleagues, a space that is respectful and safe, and a space that promotes this approach of providing whole health care where individuals can get a variety of services that they need to improve the quality of their lives. I could not be more excited for the creation of Garlington because it creates the first step towards a model of care that hopefully we can deliver here in Portland. We always must have support from our community in order to create these centers that really serve many important goals in our community. So we really rely on the generosity of our donors to achieve that, and we're so grateful that people believe in the work we're doing and stand with us in helping us move that forward and create places like Garlington.
Hi, I'm Dan Field, Executive Director of Community Health and External Affairs at Kaiser Permanente Northwest.
Hola, I'm Rocio Acosta, and I'm a bilingual engagement specialist with Kaiser Permanente.
Hello, I'm Tracy Dan Grace, Director of Community Health at Kaiser Permanente.
Hi, I'm Aaron Waters, and I'm an Equity, Inclusion, and Diversity Consultant for Kaiser Permanente.
Hello there. I'm Ron Scholes, and I manage the Northwest Employee Community Engagement Initiatives.
We're sorry we can't be together in person.
We applaud you in your efforts in working in innovative ways to serve our community members in need of vital services.
Congratulations on your accomplishments.
And thank you for all you're doing to support our most vulnerable community members in this unprecedented time.
We miss being able to gather together
And celebrate the great work you're doing in the communities where we live, work, learn, and play.
But we are navigating these uncertain times together.
And together we will become better equipped for a new normal.
We are resilient.
We will persevere.
And we will once again thrive.
Yes.
Nearly 1 in 5 U.S. adults currently lives with a diagnosable mental health condition. Yet the dominant treatment model is still one size fits all, focusing mostly on people's symptoms rather than their needs, goals, and dreams. We believe everyone deserves to participate in the community without stigma or fear, to have a safe place to live, hold steady employment, and to build lasting friendships. We're here to create a new narrative for mental health, to move away from treating mental health conditions as problems that need fixing and toward a model that embraces what you want out of life. We are New Narrative. Originally founded as Lukedorf, New Narrative has been serving the Portland metro area for over 40 years. Our first site opened with the guiding thought that hope, compassion, and community were the key to mental wellness. We have since grown from a single site to an agency made up of outpatient clinics, residential treatment, peer programs, a transitional age youth program, supportive, transitional, and independent housing, homeless outreach, and housing navigation. We still believe that hope, compassion, and community are the keys to mental wellness, but we also know there are many ways to get there. We believe achieving meaningful impact requires us to think differently, see differently, and work differently. We are intentionally working to change a system that identifies people by their diagnosis into a system that values the person. A system that understands a diagnosis is something a person experiences, but isn't who they are. We're here to change the narrative on mental health services, to retire the term mental illness and focus on mental wellness, to stop containing and start embracing, to ensure that people seeking services can find a safe place to live, hold steady employment, and build lasting relationships. We believe the health of a community comes from the visibility of its people. We all deserve to be heard, seen, and recognized. It's your story. Live it your way.
without Cass, where's everybody gonna go?
You're broken down and tired of living life on the merry-go-round.
Me right now, I actually would probably be on the corner homeless.
See it in you, so we gon' walk it out. Move mountains. We gon' walk it out and move mountains. And I'll rise up, I'll rise like the day. I'll rise up, I'll rise unafraid. I'll rise up, and I do it 1,000 times again. And I'll rise up, I like the waves. I'll rise up, in spite of the ache. I'll rise up, and I do it.
I'd definitely be on the street if it wasn't for Cass.
The silence isn't quiet, and it feels like it's getting hard to breathe. And I know you feel like dying, but I promise we'll take the world to its feet. Move mountains, bring it to its feet. Move mountains, and I'll rise up, I'll rise like the day. I'll rise up, I'll rise unafraid. I'll rise up, and I do it 1,000 times again. All we need is hope, and for that we have each other.
If they come here and want their life on track, this is the best way to get started.
In spite of the ache, I will rise 1,000 times again. And we'll rise up, I like the waves, we'll rise.
There's no better place. They give you what you need, and the case managers are so caring.
Do it 1,000 times again.
Hello from sunny Phoenix. My name is Lisa Glow. I'm the Chief Executive Officer for Central Arizona Shelter Services. I've been in this role now for 3 years, and it has been an amazing roller coaster ride, probably one of the best jobs I've ever had in my life. My background is in law. I became a lawyer in my 20s, practiced for a short while, realized what I really loved was community work. I then went to work for former Governor Janet Napolitano. I was with her for about 7.5 years, and that's where I really learned about policy, state budgets, politics, and how much you can get done on the government side. So advocacy is a big part of what we do here at CAST. It's part of our DNA, has been for 35 years. After working with Napolitano, I went to run a nonprofit and realized that that was more of my forte that I wasn't going back to law. And then for 9 years after that nonprofit, I consulted. My specialty was in fundraising, building the infrastructure of nonprofits, program development, and helping them get to a new level of delivery of services. 3 years ago, I was recruited for this job, and it really seemed like the perfect fit because homelessness is political. People are suffering, and there's a lot of fear and poverty, and the politics cannot be understated around what we're dealing with in this arena. And that'll be part of my presentation. Public policy is critical, and fundraising, of course. If you're a nonprofit CEO, you have to know how to fundraise. And during COVID, we've had a lot of challenges, but a lot of opportunity. So today I'm going to be talking about our agency, Central Arizona Shelter Services, located here in Phoenix, Arizona, and the lessons from COVID and a pathway ahead, and where I think we can go next to really take advantage of a terrible situation, a crisis. Never waste a crisis is going to be my fourth lesson for you. Looking forward to meeting you all, and I will look forward to taking questions from you since this is pre-recorded at a future time, and will provide my information at the end. Thank you. So for 35 years, CAS has been leading the charge to end homelessness. As I said, we're going to talk about lessons from COVID-19 and the pathway ahead. Next slide. We celebrated 35 years this year. CAS came about because we had a homeless crisis in the greater Phoenix area. It was such a significant crisis that we made national news in Newsweek, and not in a good way. The city without a heart is what we were called. Our mayor at the time, he was a brand new mayor, decided something needed to be done. The firefighters and other community leaders got together and they decided to create a nonprofit, which they called CAS. We opened our doors in downtown Phoenix in 1984. And at that time, we were serving both adults and families in a 2-story shelter down here on Madison Avenue. Now, 15 years ago, the Human Services Campus was founded. CAS was one of the co-founders of that. And so 15 years ago, our adult shelter moved to the Human Services Campus, which is a collaboration of partners that have medical and dental and behavioral health and food and all kinds of services. Our adult shelter is 470 beds at the Human Services Campus. Our family shelter is now located in North Phoenix, about 100 beds. And recently in June, we opened a COVID-19 hotel accommodation for seniors. I'll talk about that later. We currently have 65 seniors. We should have more soon if the city of Phoenix is going to vote in favor this week for that, and we'll have more soon. We also provide rapid rehousing and other services as well. Next slide. This is what our downtown facility looks like. Our mission: to prevent and end homelessness among individuals and families while advancing compassionate community solutions. I wanted to share that because we redid our mission this year. We added prevention to the title, and it was a significant conversation for us because we know we need to do more at the front end to prevent homelessness because it is rapidly on the rise, especially here in Maricopa County. While advancing compassionate community solutions, that is to reflect that we believe we must work together to advocate for community solutions. It's not enough to just provide services. We've got to be at the forefront of our thinking in advancing new solutions. Our vision: a community where everyone has a home. Average served, 5,600. Next slide. We have a lot more data. I'm not going to be sharing it with you, but happy to share it later. I really want to get into the lessons from COVID. Lesson 1, homeless emergency response systems. That's what we do as an emergency shelter. And I'm going to talk about the good, the bad, and the urgent that came out of COVID. Lesson 2, the congregate shelter response. Lesson 3, serving the most vulnerable during the pandemic. And lesson 4, never waste a crisis. Next slide. First, I will be talking about some of the good that happened. Well, luckily, as an emergency provider, we could quickly adapt using our expertise. We started by shoring up our mission, saying our first priority has to be safety keeping people safe. We had a daily phone call for months at 4 p.m. among all of our team. We had a new chief operating officer who'd been with us for 3 weeks, and she quickly took this on. And it was remarkable to watch what happened from that. Policies and procedures were put in place quickly. We were working with public health, top priority, and working with partners, and I'll talk about that later. The second part of our shored up mission was to shore up all of our housing programs because we wanted to get people housed as quickly as possible. Communication, absolutely critical, and failing quickly was another part of that quick adaptation. And there were a lot of conversations about, let's try to get this hotel, and do we have enough money to do that? Back in March, we didn't get our hotel until June. So we had to think philosophically, how are we going to get through this? How do we adapt quickly? Collaboration, secondly, was critical. Working with the Human Services campus, working with public health, and working with a health provider called Circle the City, we were able to coordinate on an 8:30 a.m. daily call led by the Human Services campus to figure out what to do. We had disagreements. We came together around common issues, and that call still happens now. It was happening on weekends. It's only 5 days a week, that 8:30 call. And the coordination is pretty remarkable. So someone who may test positive, and weekly testing is happening here, would quickly go to a hotel that's being run by Circle the City for people who are COVID positive. We had many new partners emerge from this, United Healthcare being one of them. I won't go into all of the details on that. It's a whole nother lesson in itself. Also a forward-thinking solution, but they're helping us get people housed. That did not happen before. The CARES Act and other funding, as most of you probably know, provided some critical resources. Our concern in the future is when those resources go away, how do we continue to carry on what I believe is a more appropriate level of services for people in need? We created new programs at CAS, including an indoor program. So with 470 people in the past, people would go and get other services during the daytime. Our most vulnerable now stay indoors at CAS, and we're doing new programming based on what those clients want. We surveyed them. So that's a positive outcome. Similarly, in the community, new programs were created. The City of Phoenix created a homeless plan and a housing plan that you can take a look at on their website. There's a lot of lessons out of that and a lot to be coming in the future. And we shored up our systems lastly. This is a really exciting thing for us. We were able to get a new field in HMIS to collect insurance data. And I don't know if you have that in your community, but it's taken a long time. It was a conversation for 2 years, and we just got it done because we were tired of waiting. If we were going to be able to work with United Healthcare and Mercy Care and others and get them client information, we needed to collect it. And then we developed a new screening tool for seniors. Next slide. The bad, insufficient shelter beds and lack of affordable housing. Our point in time in January for Maricopa County identified 7,419 people as homeless. The real crisis is in the unsheltered. 51% are unsheltered. We do not have enough beds. And we've had unsheltered numbers rising throughout the entire valley. In the West Valley of Phoenix, 219% rise. In the East Valley, there's cities, it's not of Phoenix, but there are different cities. In the East Valley, 129% increase and not enough shelter beds. People do not all want to come to our shelter, plus we don't have enough capacity, so we need more beds. We have seen in our point in time, increased number of youth, seniors, and veterans became homeless, but family homelessness declined. Next slide. The urgent is our next slide. Maricopa County holds 70% of the state's homeless population. We've seen a dramatic rise in street deaths this year. We have the highest eviction rates in the nation during the pandemic, and we had the second highest before the pandemic. Our researchers at the University of Arizona project a 30% rise in homelessness, and COVID exposed weaknesses in our system that need to be addressed. These are urgent, but while we're dealing with the crisis, we're not going to get to address all of these. But the reason I put this slide here, policymakers and leaders need to know how urgent this is, and we have to raise our voices. Next slide. Lesson 2, our congregate shelter response. I mentioned a little bit about this, safety first, relying heavily on CDC, USICH, and local public health guidance, and those were ongoing communications. We had to implement also social distancing and reduce the numbers at our adult shelters. So we're currently capped at 400. Challenges, I will say the number one biggest challenge has been staffing. We had a staff of about 68 before COVID. We now have 100, and we have open positions. So when you get new funding to do things, that means you've got to hire staff. We had some staff who left who were afraid of working. So we had long-term staff leave. It was problematic. Contact tracing, we had to do it ourselves. We're still continuing to do it. So we had to learn how to do that. Program changes, weekly testing, cleaning and sanitizing, probably similar things to what most of you have seen, but a lot of lessons just from those challenges. At one point within our adult shelter, we had to do a quarantine shelter. That was a huge challenge, but we did it, and public health helped us out. People didn't necessarily want to stay indoors. It was in one of our large dorm areas where about 100 men were quarantined. And challenging to ramp up our housing programs, but we had the funding, so again, staffing. The last point on here that I want to pause on for a minute is a flexible financial assistance and prevention program that we created at CAS in 2017. It was created by frontline staff because they recognize rapid rehousing is not enough. There are a lot of people who don't qualify who need one-time assistance, and we can quickly help them end their homelessness. In fact, since 2017, we've helped 1,237 people at an average of $500 per person with this one-time assistance. And what it looks like is they get one-time deposit assistance, one-time travel assistance. We've even done eviction prevention. Now, when COVID hit, we didn't have a lot of funding in the program, and we've been able to raise private dollars for it. And we've always had to allocate, okay, we only have 3,000 this month. How many people can we help? What I instructed our program team to do when we got some funding secured, caps are off. If you have people who qualify, we do not want a waiting list, just help who you can. And so one grant we got for $60,000, we spent it really quickly and got a lot of people housed in a bad housing market quickly with that one-time assistance. Next slide. Lesson 3, go back to lesson 3, which is serving our most vulnerable. So CAS has made serving senior citizens a high priority since I started here 3 years ago, and we saw our numbers rising. 30% of the homeless population now are over the age of 55. The projections by national researchers are that we will see a tripling of the 65 plus population by 2030. And in March, we had 184 of our 470 adults over the age of 55. Most had health issues and disabling conditions. So of course we were extremely worried. So we talked to our partners, we talked to the county, the city, of course the campus that we're on, United Healthcare and others. And what happened from there was some smaller hotel shelters started to open up. Some were run by other nonprofits. The Human Services campus took a part of the campus and had a 40-bed smaller shelter so we could get 40 of those 184 out. But we kept on marching forward because we knew these were the most vulnerable. So in June, with money from the City of Phoenix CARES Act funding, we got a hotel. Project Haven Hotel is what we call it. The remarkable thing about this is it's within a hotel that is still serving other people, and nobody in the neighborhood even knows we're there. That was important because we didn't want to have people fighting us getting in there. And it's a nice hotel. It's for people 60 and the medically vulnerable. So if you're over age 60, so there could be someone who's 50 who has HIV/AIDS, and that person would qualify. There could be someone in their 40s dying of cancer, and that person would qualify. And those are a lot of the real clients we've been serving. The services at Project Haven are more intensive than at our adult shelter. 1 to 15 case management ratios, intensive housing services, including with partners like United Healthcare and new behavioral health partners who have housing resources. So putting this together in a new model to better meet the needs of the seniors is what we did. To date, we've served 124 people, 34 have been housed, 44% enrolled in behavioral health. If you want to learn more about this model, I'd be happy to talk to you further and tell you about it. Now, In March, I'm going to hold up a newspaper. I don't know if you'll be able to see it, but we'll send a copy of this. The Silver Tsunami of the Homeless, the front page of the Arizona Republic. I'll hold this up after because I don't think you can see it right now. The front page of the Arizona Republic had an article, Silver Tsunami of the Homeless. Cass had been working for 2 years at our state legislature to get an appropriation to open a shelter for senior citizens in the West Valley. And remember the slide where I showed you we've had a dramatic rise in unsheltered in the West Valley? Well, we worked with our political leaders in the West Valley to make this happen. This bill was with bipartisan support, sponsored by Senator David Livingston, a conservative Republican. This was a totally bipartisan effort. It was remarkable. And we had the appropriation moving forward, had this front page article, had the political will. March 11th, March 12th, our state shuts down and all budget bills are pulled at the legislature. So we did not get the funding. We'd worked the year before on it and we didn't get the funding the year before, even though there was some money put into the budget. We're still going to keep going forward to get this senior shelter. The political support is there. We have been working on building our programming for seniors for 3 years now. We have a team that works with our most vulnerable seniors. We have new screening tools, and we're going to continue this effort. And I bring this up to all of you because I think it's an opportunity for us to serve a vulnerable population, to get into communities and take care of that 30% of the population in a new way. Next slide. So, never waste a crisis. Emerging opportunity and innovation. I think when we have a crisis, it's the perfect time to challenge assumptions and make things happen. We've got CARES Act funding. We have places around the country looking at opening hotels. We have temporary places open now that we should try to make permanent as well. It's also a good time to talk about new shelter and housing models. We need to put them forth and act upon them. One of the things we did about a month ago, and it was a grant with a partner to purchase a hotel through United Healthcare. They have Home Matters grants, and I think they're across the country. If not, I think they will be coming across the country in the near future. Our grant scored very high, but they decided they would not award any $1 million grants at that time. They told us to apply next time. If we had gotten that, we would have purchased a hotel, renovated it, and it would have been for transitional and permanent housing with behavioral health wraparound. So we're building all of these new models. We just need to get the funding and build the political will in communities. The third bullet here, I believe we need greater flexibility in housing resources. That needs to continue. COVID has given us that. We get money from the Emergency Food and Shelter Program, and there was more flexibility built into some of those COVID dollars so that we could help people with eviction prevention. We've done about 100 eviction preventions. That's not our core business, but with the flexibility, we see it as there's no wrong door. Let's help people when they are finding us. Let's do what we can within the terms of our programs. And I think in the future, we need to demand more flexibility in housing resources from our big funders, government especially. Fourth bullet, more services tied to housing first are needed. Well, this is something we believed before the pandemic. We still believe that we need more follow-up resources. We need more resources when you put someone into a housing first program for them to succeed. I think far too many people fall out of the program because they don't have the right level of support. Fifth bullet, greater focus on prevention at all systems level. Diversion is a critical piece of keeping people out of the system. What we're doing once they're in the system and in our shelters, we consider prevention, our financial assistance program, maybe it's a secondary prevention. I think we need to create the conversation to figure this out. More prevention at all levels, because we are facing a big eviction crisis. Next, smaller shelters and specialized services. There's a lot of conversation here in Phoenix, including in the city of Phoenix's homeless plan. The senior shelter model that I talked about would have been smaller and specialized for them, and we're still going to continue to pursue that. We're going to go to the legislature again this year, but we've got some other things that we're working on as well. Right now, there are CARES Act funds that are being used in some communities to purchase hotels. We tried to buy one, but then the city council decided they didn't want us in that community, but we're still working on it, other communities. These smaller shelter models that I would envision, and this is from listening to the needs of people and what our staff say, people with disabilities, people with serious mental illness, seniors, youth. Now, some of these things exist, but not on a scalable level. And throughout our county, with 51% being unsheltered and with huge regions of the county not having any shelter, I believe this is the way to go. It's going to take political will. The only way we're going to get it done is we must build the political will and help communities overcome fear. That's a whole conversation in itself. I feel like we have to learn from each other where we can to do this. Part of what CAS has been doing for 35 years is we've had strong relationships with our cities and municipalities, and we need to continue with that. So the conversation around seniors is one where it's a benign population. And that's why we think it's a real place to start to open more of these specialized shelters. Next slide. Go back to the last slide. I forgot to talk about one thing. And when I talk about new homeless solutions, we just received a grant to form an alliance with other providers. And what we're going to do with that is it's for 1 year. We want to build our collective advocacy so we can have more of an impact at our legislature. Our state does not put very much money into our homeless services line item. Some states put a lot. Ours, there's about, I want to say it's about 5 million. This is the year for us to go forward collectively and try to increase that line item. I have no doubt about that. So our new Homeless Solutions Alliance will be with providers. There are cities who will join it. We have facilitators we're going to be hiring. We'll form our charter and work, of course, with our state advocacy group, the Housing Coalition. But this is very targeted right now on homelessness. And we're going to pick 2 or 3 things that we can do together. So if you want to learn more about that, we'll be developing our charter in December and are happy to share what we do. And we'd also like to learn from you if you're doing this. Okay, next. So what do we want to say was achieved at the end of the crisis? We want to be able to say we protected people and did our part to minimize community spread, that we moved thousands of vulnerable people to permanent housing, maybe hundreds would be more appropriate because we don't have enough affordable housing, but it's aspirational, that we created and demonstrated new shelter housing models, and that we converted one-time opportunities into permanent funding for operations, new beds, and housing. CARES Act money is still available, and there should be another bill that gives us additional. But if we don't have the political buy-in and neighborhood buy-in to convert some of these temporary locations into permanent shelter, it's not going to happen. I would like to be able to say we overcame neighborhood and community objections to creating more shelter and housing. I want to be able to say we implemented meaningful racial equity and social justice initiatives. We are going to be interviewing someone to come on part-time for, I think the title is going to be Equity and Social Justices Director, something like that. And it is a priority right now with a lot of the funding community, and with the inequities that exist and disproportionate representation of people of color, we think we've got to make this a priority. I want to be able to say we improved our systems, including crisis response, data, and reporting. And lastly, that we built strong and lasting partnerships. One of the other things I forgot to mention we created during this is a new database system called MyCast that's going to help us better pull out data. It's still in development. We use HMIS, but there are some limitations. So we hired someone to help us with this. And we are also on the pathway to becoming a Medicaid provider. Remarkably, we don't have that right now, and we should. Okay, last slide, I think, is for questions. Go ahead, and let's thank you for your time today. I'm gonna wrap it up here in just a minute. I have one more document I'm going to show you called Senior Housing Solutions, Paths to Ending Senior Homelessness. I mentioned how we were at the state legislature, and you can see in the column here, Senate Bill 1283 in the second column is what we were pursuing this session, but then COVID stopped all budget bills. When we were lobbying at the legislature, we heard folks asking, so great, you get them into some sort of a bridge shelter, then what do you do afterwards? Well, we all know we have an affordable housing crisis. Maricopa County is particularly problematic, and our rents are rising and people are being evicted, as I mentioned. So we put together this document. It's a work in progress, and I just wanted to share it with you because this is how I believe we need to start thinking. What are from prevention to other alternatives? And when we start our alliance work, we'll share this with folks. We've shared it with others. As we look forward, how do we start thinking about new solutions now? And on here, building more affordable housing is one piece of it. But some of the things that I think we need to look at, intermediate services, if you look in that, like neighborhood integration, there are models that are working where people are in neighborhoods and nobody knows they're there. There are low-income rentals, transitioning in place, scattered site programs, roommate sharing. Our area agency on agency does Age Connect. But are we tapped in enough to really take advantage of all of these? I would say we're probably not, if we don't know about them. And then what can we do together to scale up things that are working? So that intermediate services, for me, given we're in a crisis, is where I think we could get really creative. So we'll share this document with you as well. And again, it's a draft, a work in progress. So thank you. So thank you everyone so much for your time today. I really enjoyed this opportunity. Putting this together helped me also think about what we want to achieve next year. Taking the time to think strategically when we are all so busy is so critically important. So thank you for the opportunity. I'll share my cell phone and my email for any of you who might want to connect further. I look forward to learning from all of you as well. Enjoy your conference. Thank you.
Without Cass, where's everybody gonna go?
You're broken down and tired of living life on the merry-go-round.
Me right now, I actually would probably be on the corner homeless.
See it in you, so we gon' walk it out. Move mountains. We gon' walk it out and move mountains. And I'll rise up, I'll rise like the day. I'll rise up, I'll rise unafraid. I'll rise up, and I do it 1,000 times again. And I'll rise up, I like the waves. I'll rise up, in spite of the ache. I'll rise up, and I do it.
I'd definitely be on the street if it wasn't for Cass.
The silence isn't quiet, and it feels like it's getting hard to breathe. And I know you feel like dying, but I promise we'll take the world to its feet. Move mountains, bring it to its feet. Move mountains. And I'll rise up, I'll rise like the day. I'll rise up, I'll rise unafraid. I'll rise up, and I do it 1,000 times again. All we need is hope, and for that we have each other.
If they come here and want their life on track, this is the best way to get started.
I'll rise up, rise like the day. I'll rise up, in spite of the ache. I will rise 1,000 times again. And we'll rise up, I like the waves. We'll rise.
There's no better place. They give you what you need, and the case managers are so caring.
Do it 1,000 times again.
Whether you are recovering from an injury or illness or looking for support and guidance to live a healthier life, Samaritan Health Services wants to be a part of your journey. Together, we can achieve wellness, strength, hope, and joy. Find inspiration to live your best life in stories of triumph, resilience, and determination at samhealth.org/together. Samaritan Health Services, building healthier communities together.
If you remember one thing today, remember this. You matter. And because you matter, the world is better when you're healthy. That's why Care Oregon helps our members get the care they need from the Oregon Health Plan. And lots of good things beyond health care. When you're stronger, you make everyone around you stronger too. That's the Care Oregon effect. Learn how to apply at careoregon.org/OHP.
Hello there, my name is Ash Us, and I am the Advocacy and Partnerships Coordinator at Andre House of Arizona. Andre House is a basic needs center for people who are experiencing homelessness in Phoenix. Every day, we open our doors and provide things like clothing, hygiene supplies, blankets, and most importantly, hospitality to people who are on the streets in Phoenix, Arizona. On any given day, we serve between 450 and 500 meals to people in our community. Not all of the folks who come into Andre House are currently experiencing homelessness. In our most recent demographic survey, we know that about 50% of the people who come into Andre House are sleeping on the street at night. We also know that about 30% of those individuals are currently working and employed. The remaining individuals are staying at CAFS, which is the shelter located across the street at the Human Services campus, and a small portion of the people who come in for our services are currently housed and just in need of a little bit of help to get by. I've been at Andre House since 2017. I moved from New York and then Boston, and from Boston to Phoenix to become one of the year-long volunteers at Andre House. Andre House is a unique place in the sense that the basic services are operated by 5 to 7 folks who are fresh out of college, or in some cases, even at a later stage in their life. And they commit to doing a year of service and living in intentional community with one another. During that year, you eat all of the food that you serve at Andre House. You get your own hygiene and clothing and basic needs supplies from Andre House as well. And you receive a $200 a month stipend in exchange for your service. This was really where my experience with homelessness started, at least at the professional level. In the year that I spent doing a year of service with Andre House, I was so privileged and fortunate to get to know hundreds of people who came in as people needing a blanket or a toothbrush, people who would come in every day, people who I would build meaningful relationships with. At the end of that year, I found myself really rattled by a lot of the things that I had seen. The most frustrating part of that experience for me was seeing how difficult it was for the people coming into Andre House to end their homelessness. People have so many barriers that lead them to being on the streets in the first place. And I observed how all of these barriers intersected and often compounded one on another and made it just increasingly more difficult for people to get off of the streets. I personally knew about some of these barriers. My initial call to homelessness was really from my own experiences as a young adult. My mom and I fell on some tough times, and I was so fortunate to never have to spend a night on the street. We had people who could take us in. We had an awesome St. Vincent de Paul who was able to provide us with services. And because of that, I was able to get a little bit of help, go on to college, and move forward with my life. But every day that I was at Andre House, I would meet countless people who had just been dealt one bad hand after another. People who, despite trying as hard as they possibly could, they would wake up each day to encounter a new obstacle that would make it more difficult for them to exit homelessness. One of my more impactful and earliest experiences was with one individual that I knew very well. And this was an individual who had been experiencing mental illness all of his life, through his childhood and into his adult life. And he was someone who, when medicated, could work and thrive in any traditional environment. He had multiple professional experiences in great jobs. He had family, he had children. And he went through one experience of loss. He lost someone in his family, he stopped taking his meds, and he quickly spiraled. For a lot of you all who are watching this and people who work in homelessness, we know that this isn't a unique thing. We know that all it takes sometimes is one really bad thing to happen to set someone back or to delay the process of them getting the help that they need. With him, I think that was one of the more impactful experiences because he was someone that I'd come to know so well. We only got one day off a week when I was on the core staff, and a lot of times I'd spend my day with him. I'd pick him up in the zone, and we'd go to McDonald's and hang out. He became a friend of mine, and it was just really difficult to see all of these different systems fail him. He wasn't eligible for certain benefits because he worked, but if he worked, he couldn't work more than what he was currently working because of his disability, and disability wasn't enough for him to secure his own housing. So that was just kind of, for me, one of the first times that I found myself really caring for someone and realizing that no matter how much I cared and no matter how much all of the great people working at the Human Services campus or at Andre House cared, there were certain just systems that had failed him. I bring this up because these were the kinds of things that I was experiencing and thinking about and reflecting about very critically before there was a global pandemic. And I don't know about any of you, but I am surely ready for 2020 and this pandemic to be a thing of the past. But COVID has obviously made things far more challenging for the people that I work with and for the people that I know here in Phoenix. When the pandemic really started and became a serious problem. We were fortunate in Phoenix that, unlike other cities that were limited because of temperature, we could create some outdoor options for folks. And so I saw our county and some of our human services providers and elected officials coming together to create socially distanced spaces to use for people who were positive or for people who would need some sort of isolation. And I felt grateful that we had that. But I think about that time in March and April, and one of the questions that I was asked in preparing for this and in thinking about this conference was, what happened in March and April, and how did COVID impact things then? And I don't know if a lot of you feel this, but that was a time where it really tested not just myself, but all of our staff at Andre House in our ability to be flexible and to respond to crisis. When I was in college in Boston, I had a mentor who always used to talk about this example and tell people to be a duck. And we would look at her like, that was so strange. What is she talking about? But there's this story of how when you look at ducks who are floating on the water, they appear to just be coasting along and floating along the water. But if you were to look at them under the water, they're pedaling incredibly fast just to keep afloat, just to keep moving. That's how Andre House has felt since March. And it makes me sad that that hasn't stopped, but that's how it's been. All of us knew that this is what we had trained for, this is what we had been prepared for, and this is what a lot of us as folks with some sort of lived experience with homelessness or mental health or any combination of things, we know how to be resilient and how to take a crisis and how to respond and move forward. And that's how March and April felt. In Phoenix, we were really lucky. We didn't see a huge outbreak at Andre House in the way that other cities did. I remember talking to colleagues who were in other cities where there were massive outbreaks of people experiencing homelessness who were contracting COVID at an alarming rate, and we didn't see that. And what that tells me is that our protocol really worked. Between the Human Services campus, all of the organizations there, and Andre House, we quickly implemented a lot of protocol to try and reduce the spread of COVID. And whether it was that protocol or something greater than all of us that kept it from becoming a huge outbreak, I'll never know. But right now, I think I'll choose to believe that it's probably a pretty even combination of both, of people trying really hard to reduce the spread and also some sort of good luck or good energy, whatever you believe that to be. One of the main things that I've taken from this COVID experience is really the resiliency of the people that we work with. Providers and people who are in direct service talk about how resilient their clients are all of the time. But I really saw that in March and in April especially. There were a lot of people who used the services at Andre House that had developed great systems for getting their basic needs that they would otherwise not have. There are a lot of individuals who would come in every morning and pick up a hygiene pack and head on over to the public library where they could use the computers, access air conditioning, etc. There were specific restaurants that people knew that they could go to, and if they bought just one thing or said hello to the right person, someone would give them access to a restroom. There were other parts of the city, certain light rail stations where people knew there wouldn't be police officers moving them or forcing them out of the light rail station. People knew about certain parks that would be more secure or private where they could sleep during the day if they hadn't slept all night. In March and in April, for so many of these folks, these habits, these routines, they became completely disrupted. People could not access libraries, restaurants were closed down. Somehow there were even less access to public restrooms and hand washing stations than ever before. And our guests were certainly stressed by that. We had to make adjustments to Andre House as a consequence, but people were strong. They were resilient, as many of them have had to be their whole lives and figure it out. And what I found, and I'm kind of embarrassed and both humbled to admit it, is that our guests are resilient beyond belief and they could adjust to the changes. It was many of the service providers and many of the people that I worked with who were struggling more to respond to COVID, because the thing that we forget and don't often speak about with people experiencing homelessness is that for people on the streets, every day is a crisis. Even the people who wave hello to you or come into your case conferencing meetings, or people who show up for your one-on-one and are in great spirits, they're like those ducks in the duck example that I was talking about. They may be friendly and they may be doing well and cheerful, but at the end of the day, there's no part of homelessness that is a normal or healthy situation. People are existing in crisis mode every single day. And the pandemic exacerbated that, but this is a population with a skill set in thriving and adapting amidst such awful and atrocious things thrown at them. So that was one of the major things that I learned. Another takeaway that I think I've learned from this, and I hope that we as a society and a city and even on a more national level can really learn, COVID has taught me to really check my own privilege and the blessings that I have. One of the most common things that happened is that people would come in as soon as we opened every morning and say, my doctor is only doing telemedicine. I'm out of my prescriptions, my psych meds, and the only way that I can get a refill is if I do a telemedicine visit with my clinic. I don't even have a phone. How am I supposed to do that? And I think that can teach us all about some things which we maybe did not realize, which is that a lot of the innovative and adaptive things which we've done in response to COVID in this virtual age of Zoom and all of these other digital things, in moving to that direction, there are people who are excluded by those changes. There are people experiencing homelessness who don't have access to technology to participate in the things that they need to do. There are a lot of people who are part of the working poor and people who are susceptible to falling into homelessness who don't have access to technology and cannot take advantage of the different benefits and things which are made available to them. One particular story that I think kind of sums up my experience with COVID and very specific to Phoenix was a particular day in the middle of the pandemic when this Maricopa County had opened up the socially distanced parking lots, and elected officials and Phoenix police officers and some folks within the different departments within the city of Phoenix collaborated and took that as an opportunity to move people from the easements and install poles and chains. Now, these county parking lots that were opened were parking lots that were designed to, like I said, provide socially distanced spaces for people, whether they were positive or symptomatic or even vulnerable. The goal of opening these parking lots was to create a space for people who really needed the sort of social distancing, which was not available when there were hundreds of people on the easements. But I remember waking up that morning. And being incredibly tired by working almost 2 full-time jobs, cooking and doing the basic services at Andre House, and then my administrative job in the evenings. And I found out that this was happening, and I stood on the corner of 11th Avenue in Jackson, which is where I work, and just watched all of these folks be told, you have to go into the parking lots or you have to go somewhere else. And I'm thinking about some of the things that I've said earlier. You know, people are really struggling. People are going without. Everything is in chaos. Why are we using this as an opportunity to move people? This is why is now the time to move people from the easements and install poles and chains to keep people from ever returning. I was frustrated. I was tired. I was sad. And I sympathize deeply for our guests because I could never imagine what that would be like. Someone coming up to you and saying you either have to go into a parking lot or you have to just get lost and go somewhere else. When that happened, if this was a normal time, and we know that this year has been anything but normal, we could have instructed people to show up to City Hall and make a comment at the City Council meeting about this, or we could have organized large groups of people and advocates, folks who weren't okay with this. But we couldn't do that because all of our City Council hearings and all forms of engagement as far as that's concerned are now happening virtually, which, to what I said earlier, those things are inaccessible to people who do not have access to technology. I think one of the other frustrating elements of that was that some of the CARES money that we received for supporting people experiencing homelessness was used in that process of installing poles and chains. The way that it was explained was that the process of doing so pushed people away and in some sense did create more social distancing because people were not camping right next to each other on the easements. I also know that the CDC recommended that cities do not break up encampments at this time, as that could lead to a greater spread of COVID. One of the neat things, though, was that the city of Phoenix did make a great investment in opening up the convention center for heat relief. As I said earlier, in March and April, there was really no significant problem in people being outside, sleeping outside. And then we started the summer, which every year can be deadly for people, or is deadly for people experiencing homelessness. But this summer, now with more people outside than ever before, we were particularly concerned about the heat. So the city of Phoenix opens a convention center to be able to provide weather relief during the day for people who are experiencing homelessness. That, in my mind, was a really great use of some of the CARES money in our city. So I guess in thinking about both of those things, it becomes a challenging thing for people working in homelessness, for folks like myself. On one hand, I was really grateful that the city of Phoenix was investing this money in day relief and providing shade and cooling to people who needed it in the midst of the pandemic. At the same time, I was incredibly frustrated and devastated that the city of Phoenix was using some of its resources to displace people and push people experiencing homelessness out of the easements and to other parts of the city where there were less people who were likely to complain about them and them not having access to a restroom. So what is the balance of that? And what is there to be said about witnessing so closely such meaningful and impactful things and things that are so destructive and harmful? That, in a sense, is the last thing that I really share and the last point that I would make about what COVID in the city of Phoenix, as someone working with people experiencing homelessness, has taught me. And that is, for the people that we're working with, everything is essential. When the COVID pandemic really started, you saw the separation of essential versus non-essential workers. Things like a haircut were deemed non-essential. And I have a lot of family members, my dad included, who was very frustrated that he could not get a haircut. And between all of us, long hair really isn't a good look for him, so I get it. But things like that were deemed non-essential. Restaurants, non-essential. Libraries, non-essential. Spaces for people to plug their phone and just hang out. Coffee shops were non-essential. We made the right call in closing those things down. But what we didn't think about and what we're left to continue thinking about as we move forward is this ultimate challenge and the goal of my work and what I think we're all called to do, which is to take a step back and spend time with people who are on the streets and understand their lived experiences, or at least try to. We'll never understand. I'll never understand. But in taking a step back and having conversation and getting to know people, that's how we see that our perspectives and what's essential versus what's non-essential, it's such a product of our privilege, of our experiences, of the struggles we do or do not have on any given day. In preparation for this, I spent a little bit of time this week and last week just floating around Andre House and asking people to tell me about what COVID has been like for them. That in itself is a process that I think beyond COVID, we could all make a lot more time for. That is the art of being out with people and asking, how is this impacting you? And what can I do as a person who cares about you to make this day a little less difficult? So I'm just gonna go through some of the things that people have shared with me about COVID, because as I said, before the pandemic, there weren't a whole lot of ways for people on the streets to have a voice. In this digital age, there are even less ways. And I think that as much as we can try and strive to safely spend time with them and understand what they're going to, or like I said, try to understand, the better we will all be at this painfully difficult and challenging and beautiful and inspiring task of trying to end homelessness in the city of Phoenix. Can we pause it? Sorry, the dog is drinking water.
Yeah. All right, we're recording and I'm going to mute my mic now.
So I'm going to spend the last part of my time talking about some of the things that I've learned and the things that people have shared with me. These are folks who are experiencing homelessness in the city of Phoenix. One person, we'll call her Dee, when I asked her about what was the most challenging part of the pandemic for her, she said that what was most difficult was that getting her appointments scheduled was now even harder. I asked her to talk to me a little bit about that, and she gave some really great examples. Dee is someone who goes weekly to her SMI clinic to access some mental health services. Ordinarily, she would come on into Andre House, use a phone, call her insurance, and make sure that her transportation was scheduled to take her to the clinic. She'd wait at Andre House, and then she'd go over to her clinic. Usually when she would get there, they would say it's going to be a little while longer, and she would walk across the street and go into the Dunkin' Donuts and grab a donut and a cup of coffee. She said she'd usually get vanilla frosted, which made me laugh because back when I ate a lot of donuts, that was my favorite as well. She would go in and get a hot coffee and a donut and go back inside and wait for her name to be called for her appointment where she would see her provider every week. Now, her practice of going to access mental health care is much different. There are limited appointments now to reduce the number of people who are in the office at any given time. She's able to go every other week instead of every week, which is inconvenient and both traumatic for her as someone who relies on her routine and someone who depends on the regularity of her schedule. So she goes every week now, and she comes to Andre House still to use the phone and call to make sure that she has transportation. At Andre House, though, our building is not open to people. We're doing all of our services in the parking lot, which means that the lines are longer, people have to wait longer. Sometimes she'll wait 15 minutes just to be able to get the phone and use the phone. Because there are so many people using the phones, sometimes she gets to our phone and our cordless phone is dead when it's her turn. So then she has to find a staff member who's able to give her their phone to use. Normally finding a staff member would be easy, but we don't have as many volunteers right now to protect both our staff, our volunteers, and more importantly, our guests who are more vulnerable. So she has to look around, find someone to use a cell phone. When she gets a phone, she's able to call. She makes her call and she gets to her appointment. And when she gets there, instead of being able to go across the street and wait inside to Dunkin' Donuts, she waits outside and she sits on the sidewalk until it's time for her to be called in for her appointment. In the summer, which was when the pandemic was really bad in Phoenix, Arizona, this meant that she would be sitting on the sidewalk outside of her clinic for sometimes 30 to 40 minutes in 120-degree weather for her biweekly appointment with her mental health provider. Another person that I spoke to, we'll call him E. He was someone who was staying in the parking lots. He was initially excited when a police officer came up to him and said, "We're opening parking lots for you. You can move your stuff inside. There'll be security. There'll be restrooms and access to water." He was ecstatic to go, especially when he found out that it would be socially distant. As an older gentleman with a lot of health conditions, this was a good option for him. He moved into the parking lots, stayed for a couple weeks, and things were going well. But then it became the heat of the summer, and he was in this parking lot without shade or access to air conditioning. He ended up having to be hospitalized for heat stroke and for some kidney failure that was the product of him being dehydrated and not drinking enough water. E is housed now, and he's very happy to be housed, but for him, the worst part of the pandemic was feeling like he was expected to just stay in the parking lots, lay low, and not ask for too much. Those were his exact words. I know that the world is struggling right now. I know that there's a lot of chaos, but I have to just accept that this is how it is because I don't have any other choices. And that made me really sad. You should know, though, that he is still housed. And we have plans to have lasagna together in a couple of weeks or whenever this pandemic slows down a bit and it's safe for him to have company at his new apartment. One last story, and this one is one of the more impactful ones, was that there have been people whom I know, who our guests know, who've passed away in the heat. These were not people who passed away due to COVID. These were not people who were sick before they died. These were people who were struggling with substance abuse, people who were struggling with addiction, people who were struggling with mental illness. And the two people that I'm thinking about, I've known since I first came to Andre House in 2017. There were people who spoke about folks that had died and tried to say, well, they died because of their substance abuse. They died because of their addiction. Their cause of death, as reported by the medical examiner, was an overdose or a suicide. Because of my time at Andre House, I don't accept that. I know there's a lot of us who don't accept that. Maybe those were how these two individuals that I'm thinking about had died. But when I think about the cause of death, I think about one of the very first things I said about my friend who I met in my early stages at Andre House, a person who had been failed by so many systems. These two people who passed away, this pandemic made it harder for them to access the things that they needed. Nationally, we are seeing a trend in people struggling with addiction who are relapsing, because a key part of people addressing their addiction is the community and social support which they come to rely on through groups and through settings where there are other sober people who are around. Because those things have been deemed non-essential services, there are people like the two folks that I know who passed away who are really in the weeds of serious addiction, who cannot go into churches anymore for their meetings. They cannot come into Andre House on Sunday afternoons for their support group because it's not safe for us to have large groups of people in our dining room anymore. I think of those two people and I think of this pandemic. And the last thing I'd say about Phoenix is that the city is unique. I've worked in homelessness in New York and in Boston. Homelessness is very intentionally isolated and concentrated in a particular part of our city, a part of the city that we call the zone. This is where Andre House is. This is where the Human Services campus is. This is where CAS, the shelter, is. This is an area where people experiencing homelessness are allowed to exist because in so many other parts of the city, they are forbidden from doing so. They're trespassing for existing in other places. This pandemic has taught me that separation, that isolation, even as we're encouraged to be socially distant, it only makes it more difficult for the people who are on the streets, so many of whom are struggling with loneliness in ways that I could never imagine. I've learned a lot from COVID and from the pandemic, and I'm more motivated than ever before to work on homelessness in this city, to reduce the stigmatization and the isolation of people who are experiencing homelessness, because a lot of people just don't want folks in their neighborhood who lack a home. I'm more motivated than ever before to spend time with the people that are on the streets, to ask them what they need, what they're struggling with, and what we can do to help them. And I'm also way more motivated to reach out to the people I work with who inspire me every single day. People who since March have been working around the clock in disaster response mode, nonstop, since the pandemic has started. Thank you for allowing me this opportunity to share. I wish everyone safe holidays, good health, and I wish as well that everyone is able to make the time to speak with the folks that you're working with about how they're doing and how this has impacted them. Thank you.
It's very hard for people to take care of their mental health needs, physical needs, if all you're doing every day is trying to find a safe place to sleep. We're all in this together. And the struggles that some people have, that could be anybody. That could be, me in 2 years. I don't know.
The state of mental health in the country right now is very, very challenging. There's enormous need from many individuals, and oftentimes there's limited ability to access or receive those services.
Historically, whole health care has been, you've got your primary care provider, you've got your mental health provider, you've got maybe your addiction specialists, and they're all sort of doing their own thing independently with very little communication amongst them. But whole health care for us now at Cascadia is that we're bringing all these entities together under one roof. And that's really exciting because now I get to work for a team of diverse professionals with various skill sets, knowledge, experiences, and we get to all put our brains together to really work on finding the best solutions for patients and getting the best outcomes.
So if we can address health from the behavioral health perspective first and foremost, and then add on substance use treatment, physical health treatment, housing, employment, social factors, wellness, you put all of those together, and that really wraps around someone creating a sense of whole health. So we've followed 900 individuals who have received behavioral health services who also are enrolled in our primary care as well. We found that over 80% of those individuals had not seen a primary care doctor in over 2.5 years. Over a year and a half time, we found that we reduced their utilization of the emergency department by 18% and their inpatient medical admissions by 23%. I have never seen results like that in my career, and it is a testament to an approach that can work really well to improve people's lives. It would be ideal to have more centers like the Garlington Center, a space where people feel comfortable, both clients and our colleagues, a space that is respectful and safe, and a space that promotes this approach of providing whole health care where individuals can get a variety of services that they need to improve the quality of their lives. I could not be more excited for the creation of Garlington because it creates the first step towards a model of care that hopefully we can deliver here in Portland. We always must have support from our community in order to create these centers that really serve many important goals in our community. So we really rely on the generosity of our donors to achieve that, and we're so grateful that people believe in the work we're doing and stand with us in helping us move that forward and create places like Garlington.
For over 40 years, Central City Concern has helped thousands of people to find homes, to regain health and recovery, and to build economic stability and resilience. Every year, CCC works with over 13,000 people across several domains. We provide health care, inclusive of primary care, addictions care, mental health, that is really person-centered. We provide supportive employment, walking alongside people to help them get meaningful wage jobs. And we work with people to find housing that is safe and supportive and affordable.
I went from homelessness to homeowner in a matter of 10 years. I feel, my story does help others believe that they can do it too, because I did it and I didn't think I could do it. Some people have never had a job, or maybe it's been a very long time, and so we are able to offer more compassion and coaching, getting people ready to get into a more permanent full-time position.
Because of CCC, I was able to get my prison sentence suspended
because they see me out here working and cleaning up the town. I'm 36 years old, been in recovery for 19 months and 9 days. Got 5 kids at home. CCC actually helped me change my life because I got a job that I'm able to work with the background that I have, and I'm able to feed my children, you know, and got a nice place to live, roof over my head. The people here at CCC are like family to me, especially my bosses. And yeah, they help me out with my recovery.
CCC has all the resources, the tools to get your life back in order. My name is Ralph Fakoko Tase. I was born and raised in Samoa. I didn't really think about recovery because I try to get clean on my own. You know, when you're talking to yourself, when you're trying to do it by yourself and you're trying to do it alone, it never works. I would be nowhere where I'm at without the support and the programs that CC has. I'm talking about from Hooper to the recovery program, treatment, the medical field as well. I FaceTime my son every Saturday now. For a very long time, you know, that wasn't an option. I value things today. There's so much value in my life. You know, if I can do this, anybody can.
The impact CCC has is outstanding. The patients and the clients we can reach to, the things we can help provide to them, I think they come in not knowing what we can really do for them, and then when we're able to show them that, I think they're just beyond grateful. Our care teams provide a lot. A patient can come in and just as simple as just have a checkup, but if a patient comes in that's homeless, they need more medications because theirs got stolen or their IDs have been stolen. We definitely go above and beyond and go out of our way to try to find them the resources that they need.
We're each a piece of this puzzle. We're all equal and we all have a place. When we're all in this together, we create one beautiful CCC picture.
Thank you, CCC, for all the advantages that you guys gave me and helped me out. I got integrity in my work just because of that.
Thank you, Central City Concern, and all the mentors that helped me along my way to become a better person.
And thank you to Central City Concern.
Faftai Lava CCC.
Whether you are recovering from an injury or illness.
For over 40 years, Central City Concern has helped thousands of people to find homes, to regain health and recovery, and to build economic stability and resilience. Every year, CCC works with over 13,000 people across several domains. We provide health care, inclusive of primary care, addictions care, mental health, that is really person-centered. We provide supportive employment, walking alongside people to help them get meaningful wage jobs. And we work with people to find housing that is safe and supportive and affordable.
I went from homelessness to homeowner in a matter of 10 years. I feel, my story does help others believe that they can do it too, because I did it and I didn't think I could do it. Some people have never had a job, or maybe it's been a very long time, and so we are able to offer more compassion and coaching, getting people ready to get into a more permanent full-time position.
Because of CCC, I was able to get my prison sentence suspended because they see me out here working and cleaning up the town. I'm 36 years old, been in recovery for 19 months and 9 days. Got 5 kids at home. CCC actually helped me change my life because I got a job that I'm able to work with the background that I have, and I'm able to feed my children, and got a nice place to live, roof over my head. The people here at CCC are like family to me, especially my bosses. And they help me out with my recovery.
CCC has all the resources, the tools to get your life back in order. My name is Ralph Fakoko Tase. I was born and raised in Samoa. I didn't really think about recovery because I try to get clean on my own. When you're talking to yourself, when you're trying to do it by yourself and you're trying to do it alone, it never works. I would be nowhere where I'm at without the support and the programs that CC has. I'm talking about from Hooper to the recovery program, treatment, the medical field as well. I FaceTime my son every Saturday now. For a very long time, that wasn't an option. I value things today. There's so much value in my life. If I can do this, anybody can.
The impact CCC has is outstanding. The patients and the clients we can reach to, the things we can help provide to them, I think they come in not knowing what we can really do for them, and then when we're able to show them that, I think they're just beyond grateful. Our care teams provide a lot. A patient can come in and just as simple as just have a checkup, but if a patient comes in that's homeless, they need more medications because theirs got stolen or their IDs have been stolen. We definitely go above and beyond and go out of our way to try to find them the resources that they need.
We're each a piece of this puzzle. We're all equal and we all have a place. When we're all in this together, we create one beautiful CCC picture.
Thank you, CCC, for all the advantages that you guys gave me and helped me out. I got integrity in my work just because of that.
Thank you, Central City Concern, and all the mentors that helped me along my way to become a better person.
And thank you to Central City Concern.
Faftai Lava CCC.
The Center for Vulnerable Populations is a research center, and that means we're devoted fundamentally to discovery and innovation, to new ideas, and to studying to figure out what is most effective.
The work that CVP does is so critically important because we have, as a society, evolved into one in which we have the haves and have-nots.
So we decided that a Center for Vulnerable Populations could be established with the goal of looking at better ways to improve the quality and safety and care that these patients receive.
We have a remarkably dedicated group of staff who are just as committed to the core mission of CVP as our faculty.
I'm biased because I am a staff person, but working with the staff I feel are really a big piece of the heart of CVP.
10 years ago, almost to the day, I started the center as one person. I invited Kirsten Bibbins-Domingo to join me. She now is the director of the center.
The growth of CVP has been really remarkable to me over time. When we first started 10 years ago, it was really not much more than the two of us.
By doing experiments and trying to understand what things work best for this population, we could actually identify best practices. We could identify new ways of approaching and managing patients from vulnerable groups.
Working with the CVP faculty and staff has been wonderful. They're all very kind. I actually have a good time when I participate in the studies. We laugh, and I feel like they treat me like my opinion counts.
What CVP adds is that tremendous academic spark to help us to develop and prove which strategies are helpful and then disseminate them locally and globally.
There is concern in the community about research, and I think underrepresented minorities who in the past have been discouraged to participate in research studies will actively jump forward and come forward and want to participate if we show them that we care. And the center and the people who work in the Center for Vulnerable Populations, they know that probably more than anybody.
I've been a volunteer for the Center of Vulnerable Populations as a patient, bringing in the perspective of a patient. It's not only nice, it's great that they want patients to give feedback.
The statistics that researchers offer are tremendously important, but unless they're attached to individual stories that people can understand and see, they tend to get lost.
Because of their title is Center for Vulnerable Populations, I didn't realize that I'm part of the vulnerable population, and they reached me and they helped me, so if they keep on doing the work that they're doing, they can reach others and help others too.
There are multiple contributors to health. There are things that happen that individuals do that affect their health. The types of health policies, environmental policies, housing, education policies that all ultimately have an impact on an individual and their community and how they achieve health.
Our faculty and staff have been tremendously effective in partnering with community-based organizations. We have Eat SF as a wonderful example of trying to eliminate food insecurity in San Francisco and thereby reduce the prevalence and incidence of type 2 diabetes.
My income is just under $1,000 a month. Over the course of a month, I don't even think that I have $1 a day to buy food. A social worker I know talked to me about Eat SF. I applied for it and was accepted.
SF Build is an NIH-funded project that is tasked with understanding what works for whom and in what context with respect to increasing the participation of underrepresented groups in biomedical research. If the biomedical research workforce is not diverse, we're not going to get the best answers.
The bigger picture is a campaign that is centered on youth voice and the creation of media
to counter the type 2 diabetes crisis in young people.
With the Bigger Picture Project, we talk a lot about how health is often determined or heavily impacted by what's in your environment, what's around you, what you have access to.
I want us to be taking on bigger projects, bigger ideas, and things that involve multiple faculty contributing their expertise. If we could harness all that together, I think that we could set and achieve a very clear goal.
You know, it's been an honor to work with CVP. It's expanded the way that we see the power in our own work.
I want to congratulate the faculty and staff of CVP and say you're doing a wonderful job that we're doing together and that you've been doing for the last 10 years.
It makes me feel really good to know that there's folks that are championing health, that are there for health equity, that are serving the communities that need it the most.
They should be proud of what they're accomplishing, and they should continue to work very hard to do even better. And I think we will improve the care of patients that we really care about.
Really, I would just like to say congratulations to everyone who's been with CVP for this whole 10 years. This really is a magical place, and I'm really happy to be a part of it, so congratulations.
What we're doing here is both unprecedented and nearly impossible. And one needs to suspend disbelief in this work. And we're talking about taking on major social challenges. I just hope that we keep the faith and keep going.
Hi, my name is Margot Kushel, and I'm happy to be here with you all today to talk about homelessness and COVID-19, a crisis upon a crisis. Next slide. The COVID outbreak has really created a major crisis for America's homeless for a variety of reasons that I would love to talk through today. Next slide. To lay out what we think the problem is, oops, sorry, I'm having some trouble with my slides here today. So to lay out what we think the problem is and has been with homelessness and COVID, the first we knew right from the first reports of COVID coming out of Asia, we began to worry that the homeless population would be at very high risk of both acquiring the disease or transmitting the disease because of the nature of how people experiencing homelessness are forced to live, either in congregate shelters, encampments, the use of free or low-cost food lines, social services, the lack of hygiene. These were all setups for major problems. We were concerned about health-related behaviors such as substance use or tobacco smoking that may complicate the ability to partake in activities to reduce the risk, like wearing masks. We knew that amongst people experiencing homelessness, many are essential workers who would be at high risk of acquiring the disease. And we were concerned about the cross-transmission between jails and prisons and homeless shelters or people experiencing homelessness. We also, as time went on, became more concerned about the difficulty of this population to access testing, as well as the difficulty of following up once people receive testing. We knew that this population would lack places to safely isolate and quarantine. This could not only put them and others at high risk, but could put extra stress on already overstressed hospitals, as well as increasing the community transmission of the disease. Next slide. We knew that people experiencing homelessness would be, and in fact are, at high risk of poor outcomes were they to be infected with COVID, both because of their older age, co-occurring medical conditions, and poor access to timely testing as well as healthcare. We have been concerned about the loss of infrastructure to ameliorate homelessness, the effect of the pandemic on things like shelters, libraries, free and low-cost food lines, and other services that people experiencing homelessness rely on. We're concerned about the lack of uptake or distribution issues with the vaccine when it becomes available. And finally, we're extremely concerned about the increased risk of homelessness due to economic disruptions. In this talk, I want to just briefly outline some of those concerns and some potential responses that have happened or that we hope to happen. Next slide. So first of all, a high risk of COVID transmission. Next slide. So we know that congregate settings increase the risk of acquiring COVID. About 2/3 of people experiencing homelessness live in congregate shelters. These shelters offer little ability to social distance, poor ventilation, the use of shared bathrooms. And also, once we realized that masking was incredibly important to reduce the risk of spread, it's a very different thing to wear a mask when you're outside your home, or to wear a mask 24/7 if you live in a congregate setting. Next slide. We are concerned and remain concerned, and there's increasing evidence that some health-related behaviors that are common in people experiencing homelessness may increase the risk of COVID acquisition. For instance, there's now suggestive evidence that smoking, alcohol use, and illicit drug use could increase the risk of acquiring COVID, both because of shared activities and close contact, because these activities often decrease the ability to wear masks and decrease the ability to adhere to other prevention activities such as social distancing. In a study we've recently completed in older homeless experienced adults, we found that people who reported being a heavy drinker or using illicit drug use, both of these things were strongly and independently associated with a decreased ability to social distance. Next slide. I think something that has been perhaps less well reported on and less well appreciated is the convergence of frontline essential workers and homelessness. As one of our study participants said, describing how they go from their work in a fast food restaurant back into their encampment, I work in a public place, so, I can't help from interacting with the people. The law says you have to wear a mask inside, meaning inside their fast food establishment. So I try to get it enforced where people do what the law says, but you're always going to have a hothead or a rebellious guy, and they just ain't going to do it. We have seen that the COVID pandemic has really been fueled by those, or really experienced most by those who are frontline essential workers, often low-paid workers, living in crowded housing. That story has been told quite well. I think what has been less appreciated is how many of those essential workers are actually living in homeless shelters or encampments, and really bringing that risk home to where they are. Next slide. The other point that I think always bears worth mentioning is the association between carceral settings and homelessness. We know that about 50,000 people each year enter homeless shelters immediately after exiting incarceration. 15% of those who are in jail were homeless in the year prior to jail admission. And we know that even more so than homeless shelters, jails and prisons have had some of the highest rates of COVID transmission. This interchange between people exiting and entering carceral systems and homeless environments has really been a cause for concern in fueling the pandemic. Next slide. We have seen some terrible outbreaks of COVID in homeless shelters, as we were concerned about, as we anticipated, and in fact, as has happened. Next slide. These are from some reports from the CDC. This was a study of 4 different shelters, outbreaks in 4 different cities, but in multiple different shelters, where they found after 1 or 2 cases were reported, outbreaks that encompass between 17 and 66% of all shelter residents at the time of the outbreak. This is an incredibly high rate of transmission and an incredibly concerning issue. After these were reported, there have been shelter outbreaks reported in many cities across the country. Next slide. Across 19 shelters in 4 cities, there was an overall 25% positive rate in homeless residents and an incredibly high rate of 11% among staff members. In one outbreak in San Francisco, it's notable that half of the people who were found to be infected after there were a few cases identified were asymptomatic at the time of testing. A quarter had an underlying health condition and 21% were older adults. 8% of all of those infected required hospitalization. And of those infected, it was about 2/3 of all living in the shelter were infected. 8% of shelter residents wound up requiring hospitalization. Next slide. In New York, there were, and this is thought to be an undercount, there were a little while ago, 1,400 known infections and 104 known deaths amongst people experiencing homelessness. But I think the more important thing was that they noted a 67% higher age-adjusted mortality rate than they saw in the general population from COVID. Next slide. We have done some modeling work to look at the impact of various risk reduction strategies to reduce the risk of shelter residents. We examined, built models based on a variety of outbreaks across the country, and we modeled different strategies: daily symptom screening, twice weekly PCR testing, which is the standard of care testing for COVID, universal mask wearing, relocating high-risk individuals, or a combined strategy that included daily symptom screening, twice weekly testing, universal mask wearing, and relocating high-risk individuals. I think the really disheartening part of our exercise found that even if you could do all of those things, which I want to reiterate are extremely hard to do, I've heard of very few shelters, or really none, that have been able to operationalize twice weekly testing. It's expensive and it is logistically difficult to do. Universal mask wearing means that people wear masks 80% of the time. And again, I'm not wearing a mask when I'm speaking to you from my house, and you're probably not wearing a mask in your house either. This is a very high bar of activities, but even with all of these strategies together, assuming that there was a moderate risk of community spread in your community, so that communities were not in the hot zone, but were in sort of moderate zone of community spread, one could only reduce the risk of an outbreak by 40% by combining all of these activities. What this says to me is that in current shelters with current ventilation patterns and current amounts of crowding, that even if we did a lot more than what most places can afford to do, if there is moderate or high community spread, as we're currently seeing in most parts of the United States, we can only reduce the risk of an outbreak of 3 or more people getting infected by 40%, meaning that it would be very hard to avoid having major COVID outbreaks by doing these activities. Next slide. Next slide. Other issues that are confronting us or confronting people experiencing homeless are the lack of places to isolate and quarantine. The current CDC recommendations, which may well change soon, is that anyone with a known exposure to an infected person, this usually means more than 15 minutes of contact, less than 6 feet away, is required to have a 14-day quarantine period. And anyone who is actually known to be infected by COVID needs to spend at least 10 days in isolation. This means using their own bathroom, their own bedroom, staying away from others. These activities are essential to decrease disease spread, and while we expect they will be loosened soon a little bit, they have been really the hallmark of trying to prevent outbreaks across the country. Obviously, people who are homeless, people who are living in congregate shelters do not have places to isolate and quarantine. Next slide. We have been concerned about the possibility of worse outcomes with COVID. This is partially because of higher age range of people experiencing homelessness and the known association between older age and worse COVID outcomes. Next slide. And next slide. So the risk for COVID complications increase with age, and the homeless population is aging. This is from a study we published a number of years ago that showed that in 1990, about 11% of single homeless adults in San Francisco were 50 and older. In 2003, 37% were, and now about 50% are. Next slide. My colleague, Dennis Culhane, and his colleagues have shown that this is a generational effect. Americans born in the second half of the baby boom, about 1955 to 1965, have had an elevated risk of homelessness their whole lifetime. So now we are in this bubble of the people most likely to experience homelessness, the single adults most likely to experience homelessness, are right in the age range of people at the highest risk of worse COVID outcomes. Next slide. This trend is expected to continue, and you can see we're right in the middle of this escalation where the fastest rising group of people experiencing homelessness are actually those 65 and older. Next slide. We know that people experiencing homelessness are disproportionately burdened by many of the comorbid conditions, which unfortunately are the same conditions that increase the risk of death or requiring hospitalization from COVID. Things like cancer, chronic kidney disease, chronic obstructive pulmonary disease, heart conditions, type 2 diabetes, immunocompromising states like HIV, obesity, sickle cell disease, and smoking are all highly associated with poor COVID outcomes and are very common in people experiencing homelessness. Next slide. You can see here that the risk of chronic diseases is much higher in people experiencing homelessness than it is in the general population, whether we're talking about high blood pressure, diabetes, heart problems or stroke, liver conditions, or HIV. Next slide. Perhaps less appreciated are the extremely high risk rates of smoking in the homeless population. An estimated 60 to 80% of homeless adults smoke in the United States. Smoking has turned out to be a major risk factor for poor COVID outcomes. Next slide. We are aware and concerned about the fact that people who are homeless are going to have much more difficulty accessing testing. Testing has been incredibly important for a few reasons. One, it is really one of our mainstays of preventing community spread. This is a disease that is contagious in the asymptomatic state, and so it's really important that people have access to routine screening. And it's also important that people know if they're infected to protect themselves so that they can get timely access to health care. We know that people experiencing homelessness overall have very poor access to ambulatory health care. We know they're much less likely to have insurance coverage, and when they do, it's much more likely to be public insurance. And we know that they have poor access to transportation, internet, and phones. This has turned out to be a major problem on getting access to testing. Many of the current testing efforts requires transportation to get there, requires internet and phone to sign up for testing, and testing is only as good as the ability to get your results. And so what has been found is often testing is done in these populations, but they cannot be located to let people know if they have a positive result. Next slide. We know that the homeless population overall has poor access to ambulatory care and high rates of acute healthcare utilization. For instance, in the general population, about 40% of people experiencing homelessness access emergency department in the prior year, compared to 11% in the general population. This is even higher amongst those who are 50 and older, and we know people experiencing homelessness are much more likely to be readmitted. We've been very concerned that COVID-19 is just going to compound this problem and strain already limited hospital resources. Next slide. Finally, there's no way to talk about homelessness without talking about the role of structural racism in producing it. Because of structural racism, we know that Black Americans are much more likely to experience homelessness, increased rates of about 40% as opposed to 13% of Black Americans in the general U.S. population, and increased rates of homelessness around Native Americans as well. These populations turn out to be the populations at highest risk for poor outcomes from COVID. Next slide. We know that housing problems, essential work, and poor access to care, all of which are components are affected by structural racism, compound racial and ethnic disparities in COVID outcomes. And as you can see, Black Americans, Latinx Americans, and Native Americans have had much higher case rates, much higher rates of hospitalization, and much higher rates of death than white Americans from COVID. Next slide. The COVID pandemic really also worsens the experience of homelessness. So not only are people experiencing homelessness at much higher risk from COVID, but the pandemic itself has really worsened the already horrendous conditions of homelessness. There is decreased capacity of shelters without replacements, leading to increased rates of unsheltered homelessness in much of the Western U.S. Things like the closure of libraries and coffee shops and other areas that are seen as respite for people experiencing homelessness has had a major effect on people's quality of life, their ability to access internet, their ability to find some safety. We have seen a decreased access to free and low-cost meals, worsening hunger, and worsened access to healthcare, harm reduction services, substance use treatment, and mental health care. We have often talked about how so much of healthcare has switched to telehealth during the pandemic. This has not been an option that has served the homeless population well. We've also seen increased rates of social isolation amongst all, but particularly amongst people experiencing homelessness. Next slide. The economic fallout from COVID continues to hit lower income Americans the hardest. We worry that the pandemic is going to increase the already horrific rates of homelessness. Next slide. COVID is estimated to place many, many more at risk of homelessness, and some of the estimates include up to 1.5 million families are currently on the cusp of homelessness due to the economic disruptions of the pandemic. Next slide. So what have been some responses to the pandemic, and where can we go from here? Next slide. First and perhaps foremost, in terms of trying to prevent inflows into homelessness, have been an unprecedented reliance on eviction moratoria. There's some good news here. The CDC, for instance, for the first time, issued a federal eviction moratorium that had some very good things about it and is in place for another few weeks. However, this only covers those with a legal right to housing. It does not pay back rent, and it only covers eviction related to the loss of income. People who want to take advantage of this eviction moratorium need to attest that they're trying to pay the rent, obtaining all possible support, and would become homeless otherwise. It does not cover evictions for reasons other than non-payment of rent. It does not cover back rent, and it does not prevent eviction process from being started. Next slide. Oops. Can you go to the, there we go. This is what tenants would have to do to be able to take advantage of the moratorium, is they would have to basically attest to all of these things. Next slide. So the eviction moratorium is that is a federal eviction moratorium. There were also eviction moratoriums at the state and local level, which I think I will talk about in a moment. I wanted to review some of the other CDC recommendations. For those in encampments, if individual housing units were not available, the CDC recommended that people could stay where they were and encouraged people to socially distance in encampments. Next slide. Congregate shelters scrambled to do what they could. Many started by doing symptom screening, and while they continue to do this, this has not been shown to be an effective way to prevent outbreaks, in large part because this disease is most transmissible in the 2 days before it becomes symptomatic, and because many people have the disease and remain asymptomatic throughout. Some shelters have managed to do regular testing with either rapid antigen tests or PCR tests. But as I said before, even with twice-a-week testing, which has been very difficult to sustain, it's difficult to prevent outbreaks if there's moderate or high community spread. Most shelters require masking, but again, this is quite a high task to ask people to wear a mask all the time. Many have de-intensified to increase social distancing, and many have tried to remove those at highest risk for COVID complications. Next slide. The CARES Act provided resources to try to ameliorate this pandemic, both through the Community Developed Block Grants, Emergency Services Grants, or ESG funding, and the Coronavirus Relief Funds. These have been an enormous help, but as you're well aware, these funds need to be spent by December 30th. Next slide. Project Roomkey in California was, I think, in some ways, a model response to try to manage the effects of this pandemic. Project Roomkey started being planned in March as soon as the shelter-in-place order happened, where using CARES Act funding as well as California funding, as well as funding from FEMA, high-risk homeless people were offered non-congregate shelters in either hotel rooms, trailers during COVID-19 to shelter in place, with the idea that this would lower individual risk and reduce hospital burden. To qualify for Project Roomkey, you had to be 65 or older and have underlying conditions such as diabetes, cancer, chronic lung disease, liver disease, HIV, smoking, pregnancy, or immunosuppression. Next slide. Project Roomkey also offered isolation and quarantine. So in the prior slide, what it meant was it offered people to come indoors and stay there until the program is expiring. And it is beginning to expire in many places in California. The isolation and quarantine was often run in the same programs, but separate, which is the idea here was to provide non-congregate settings like hotel rooms or trailers for those who require either isolation during COVID infection or quarantine due to the exposure to COVID or symptoms suggestive of COVID, with the goal of reducing unnecessary hospitalization and reducing COVID community spread. Next slide. So how does Project Roomkey work? Hotel rooms were leased generally by county governments with the promise of FEMA and state reimbursement. FEMA was contracted and agreed to pay up to 75% of qualifying expenses. This did not include services, but in general included things like the room costs, as well as the cost of meals and other essential services. However, this cost for people who met the FEMA definition, these costs were not given up front, and basically the counties need to put the money out and then recover the costs later. Generally, they had on-site staffing by community-based organizations or government employees, and healthcare services bridged often through local health departments or FQHCs. Next slide. This was a slide from the very early days of the pandemic, before we knew much, when we at the Emergency Operations Centers for the state of California were trying to sketch out how we could quickly identify people who were either high priority for isolation, those who went into what wound up going into the shelter-in-place hotels, or those who were infected or exposed to COVID. Next slide. After the Project Roomkey happened, and about 15,000 people have been brought indoors. In fact, there are 15,000 rooms, about 22,000 people over the course of the project. California decided to turn to something which they named Project Home Key, where they sought to identify vacant units, either apartments, hotels, motels, dorm rooms, other things that could be purchased and turned into permanent housing. These were meant for individuals or families experiencing homelessness or at risk of experiencing homelessness and impacted by COVID. Next slide. Home Key has been administered by the California Department of Housing and Community Development, which made $800 million of grant funding available through the Federal CARES Act and through the state of California threw in an extra $200 million to bring it up to $800 million. Local public entities rapidly applied for funding, and with a caveat that all funds had to be used by December 30th. So there were these rapid funding rooms, and counties had to identify potential sites, bid for them, and if they could use the funding by December 30th and met other requirements, they could be offered these funds. Next slide. Some other emphasis, other ways to treat it were the eviction moratorium. I spoke earlier about the CDC eviction moratorium. That was backed up by states and local governments that issued separate moratoria. However, none of these cover back rent, neither the CDC eviction moratorium or the state and local ones, and they don't cover those living in formal situations. So we've seen many people leak out into the streets because they don't actually meet criteria to be covered by these moratorium. Together, they've likely prevented hundreds of thousands of evictions, but without rent relief, we fully expect a wave of evictions to come. And I want to remind everyone that although the Biden administration has said that they are likely to act to extend moratorium, the CDC moratorium actually expires on December 31st, leaving a 3-week period in which we could see unprecedented waves of evictions. Because none of these moratorium covered back rents, people have accumulated large amounts of rental arrears that, depending on what state and locality they live in, they may be expected to pay as soon as the CDC moratoria lifts. Next slide. We have tried to come up with some methods to address some of these problems, and I wanted to talk briefly about our efforts to address the problem of testing in homeless communities. We at UCSF have worked closely with our community as well as the San Francisco Department of Public Health, led by community advisory boards, working closely arm in arm with community-based organizations, with community health outreach workers, who we call CHOWs. We have done a series of mass testing events, partially to get prevalence of COVID amongst people experiencing homelessness in San Francisco, but partially as proof of concept of how we can successfully bring testing to communities who have not been able to be tested successfully. In these interventions, we had the community health outreach workers who came from the community and had extensive experience in the community. We hired them, trained them, and paid them. And they spent generally about a week before each testing event out in the community, spreading information about testing, taking people's questions and dispelling myths. Many people were afraid, for instance, that if they got tested, the testing would bring them COVID. Many people were afraid that if they got tested and were found to be infected, they would be criminalized, they would be forced to go into a hotel, or worse, into a carceral system. And so a lot of what the CHOWs did was provide information, reassurance, and support. The word of mouth increased participation, and we decided from the beginning that this would be a test and treat operation, meaning that we would not only test people, but we would get information back to them, particularly if they were infected, and offer them whatever services that they needed to be safe. If they wished to go into quarantine or isolation, we would offer them that. But if they wished to stay where they were, we would provide resources to keep them safe where they were. Next slide. What we found worked best was that if we went out into the community, and you can see here from these pictures, we found that setting up a testing site, even if it was just a few blocks away from where people were, was not very effective. Instead, we put backpacks on our testers and we sent them out to street corners with the community health outreach workers and did testing literally where we met people. Teams had a community health outreach worker, a phlebotomist who did the testing, an interviewer who collected data for us, including all of the information that we needed to be able to find people if they were infected. We had physicians and nurses available if people had symptoms or needed medical attention. And we found that this worked significantly better than having a stationary site, which we also tested. It was highly accessible and extremely low barrier. We offered people a $10 gift card as well as food and information if they were willing to be tested. And we found extremely high percentage of people were willing and eager to undergo testing. And we found it easy with the information we collected to go back with the help of our community health outreach workers and find people who tested positive. Next slide. Non-congregate shelter, next slide. And I have spoken a little bit already about Project Roomkey, so I'll skip this. Next slide. Next slide. Sorry, next slide. Next slide, yes. Okay, so where do we go from here? I think the pandemic has raised all of our awareness of the dangers of homelessness and crowded housing. It has raised awareness of the racial ethnic disparities, both in homelessness and in the impact of COVID. We have found that quick action during difficult circumstances, things like action to start things like Project Roomkey and other interventions, prevented what could have been even worse death and suffering. I think the pandemic has made very clear dangers that some of us have had for a long time about the safety of congregate shelters and has really raised alarms about thinking about, can we come up with new models? Projects like HomeKey have shown it is possible when there's political will to get action to get around barriers to ELI housing creation. However, with all of these things, the scale of the response has not met the need. Next slide. We have grave concerns that as eviction moratoria lift, we're going to see major increases in homelessness. I think that the disparate impact of COVID, disease, economic disruptions, housing vulnerabilities in the Black, Latinx, and Indigenous communities really lay bare the role of structural racism in our communities and our systems and really beg a bigger response. And there's a desperate need for action. It's very important that we don't make the same mistakes we made during the 2008 housing collapse, where many people became homeless, and yet as housing prices dropped, we did not act quickly to reclaim those housing and keep them available for ELI housing, and instead lost them to speculators. There are opportunities now made by decreases in housing costs in some of our highest cost markets, but these opportunities will only be as good as their reaction to them. The lack of Senate action, particularly on the lack of passage of the HEROES Act, the lack of action on passing rent relief, really leave us vulnerable to see dramatic increases in homelessness right at a time when homelessness has never been as dangerous as it is now. Next slide. And I think all of this has left us with a reminder that there is no medicine as powerful as housing. Homelessness has really laid bare and made even more vulnerable this population during this unprecedented pandemic. And it has made perfectly clear the reason and the urgent need for ending homelessness as we know it. And with that, next slide, I'll leave my contact information, and I'm happy to take any questions.
Thank you, Dr. Kushel.
Thank you, Dr. Kushel.
I have a question. Can you tell us how providers are doing at providing psychiatric medications, especially long-acting injectables, for people who are both homeless and have mental illness?
Yeah, I think, I think COVID has made what has been a very difficult problem even more difficult. You've seen some really incredible responses of people doing things like street outreach and trying to bring medication to where people are. But I think what we've also seen are all the fractures in our system or lack of a system. What we've heard from our interviews and research in people experiencing homelessness is they have found this incredibly disoriented. Much of their coping mechanisms have sort of left, right? The ability to drop in to get care as you need it. Now, if you want to go see your primary care doctor, you're much more likely actually to need an appointment, much more likely to need a phone because they're trying, we as healthcare providers are trying to limit the number of people who we're exposed to. The rapid move to telehealth has been really heralded by many people as, a great new era. And in many ways it is. But to be honest, it hasn't worked terribly well for people experiencing homelessness. So what we have seen is incredible increases in mortality, not necessarily directly related to COVID, but perhaps more directly related to all of the disruptions in substance use treatment, reductions in harm reduction efforts, reduction in access to care for things like mental health and other physical health problems. And so I think that the answer is people are doing their best. We're seeing heroic outreach efforts of, outreach nurses and physicians going out in full PPE into encampments where they can or into shelters. But to be honest, what we're actually seeing is a major crisis caused not only the direct harms of COVID, but in many cases the indirect harms, whereas the healthcare system is really stressed to the max and is not really meeting the needs of the moment for this population.
Thank you. Our next question says, I'm a peer specialist from Benton County, Oregon. How are peer services being utilized? Have they been more effective during this time of crisis?
Yeah, I think that we've seen peer services as actually being the bright point here. I think there have been challenges because, many of the people who are peers are also struggling under the weight of the pandemic. Children are out of school. They may be facing their own health crises or economic crises. I think it was difficult to get people protection in the form of adequate PPE. On the other hand, what we've learned loud and clear is both for an effective response for things like testing, and I think it's going to be incredibly important when we move into the next phase of vaccination that we fully engage peer support. I think there has never been a more important time. What we learned, for instance, from the testing is that in many of the arenas where we have been doing these testing interventions, there were testing sites that were open and just not being used by this population. When we really partnered with peers who went out and built trust in the community, it was incredibly effective. And I know that we plan to expand our use of peers or community health workers, whatever you may call them, in everything that we do. And I think peers are going to play an incredibly important role in efforts to get vaccinations to this population as well.
Thank you. Our next question says, I'm curious how COVID is affecting homeless individuals who have to register as sex offenders and those on parole or probation. Have services or programs been reduced or eliminated?
Yeah, I think what we're seeing is services, have been doing in some ways a remarkable job to do all that they can under nearly impossible circumstances. But I feel like the Ginger Rogers sort of backwards and in high heels, everything has been so much more difficult. In many places, the percentage of people in shelters have gone way down because the shelters have needed to de-intensify, sort of scattering people to different places. Places that relied on volunteer help found that their volunteers dried up. And many of the outreach workers and things are really facing enormous risks themselves to provide services to this population. I think in some ways the untold story of COVID has been all of the secondary and less appreciated effects because of the lack of, sort of the breaking up of what was already a pretty fragile safety net.
Thank you. We have a question from Professor Lamandry of Linfield College. They say, I'm seeking people who are homeless and have mental illness showing increased paranoia and fearfulness with the COVID and with social unrest. They have been pushed out of their places to live on the streets by demonstrators and distrustful of organizations and government. How are faith organizations filling this gap?
Gosh, that is a very good question, and I'm not sure I know the answer exactly. I think, different organizations are doing different amounts of work, but I think your point is very well taken, that this is a time of incredible anxiety for us all. And I think if people had a tendency to be fearful, there is a lot of reason to be fearful now, and there's a lot of reason to be distrustful. I think that that the messaging from the government has often been very difficult. And I think that we have certainly seen people's social isolation increase, people's distrust increase, and I think for good reason. And so I think people's, have a lot of anxiety, and I think there's certainly a lot of need for us to come together. I think there's going to be a lot of need for targeted support and outreach to what is now an extremely vulnerable, very fearful population. We have found, by the way, that when we go out and we're in PPE and we're wearing masks and face shields, it certainly doesn't do a lot to promote people feeling comfortable if someone was already, had some paranoia or anxiety. And so I think this is, again, going back to the person who spoke about peers. It really raises up the importance of communities that are closest to the problem being given the resources that they need to get us closer to a solution. I think this is going to be extremely important as we head into this next period, where, first of all, we're going to see large numbers of people at risk for homelessness, and so potentially large increases in homelessness, as well as we're going to need to really get large uptakes in vaccination from a population that might have very good reason to not trust these vaccinations. So I'm certainly hoping that we can rely on community partners to really be given the resources that they need to take the lead, because I think that's where we're going to get the trust from.
Thank you. Our next question says, we saw a drop in arrest of houseless people in April and June to depopulate jails. And now, in the third quarter, a resurgence and jails are full again. What did we learn from the springtime depopulation of jails?
Yeah, that is a great question. I had the honor and the privilege of working with the National Academy of Medicine to write a report basically urging decarceration, because jails and prisons have turned out to be probably the single most dangerous place we have in terms of risk of COVID. And what we learned when there was depopulation of jails and prisons is we did not see a resultant, increase in crimes or other things. What we saw was less people placed in danger. I'm quite concerned for any resurgence of jail populations. I just don't think, I think we, no matter what you think about incarceration more broadly, and the role that it plays in society, incarceration during this period of the pandemic is extraordinarily risky. And it places at risk not only the people who are incarcerated, which certainly are at the center of the risk, but also the staff members who work with them and the community at large, because we see this as being a sort of outside in, inside out problem, where there is movement between carceral spaces and the general community. We've seen many prisons are actually in rural areas where, when they have had large outbreaks, it has overwhelmed an already stressed health system. And we've seen many, many vulnerable people become infected and die. And so I think that what I would really hope is that this is another moment of awakening and a chance for us to reckon with our tendencies to incarcerate such large numbers of people, why we do it, and what the harms are.
Thank you. When do you see people who are homeless and unsheltered getting access to a vaccine?
That is a really great question. I would advocate that people who experience homelessness should be considered to be, in one of the very high-risk groups that hopefully will get earlier access to the vaccine than the general population. You've seen different schemas put forth, with essential frontline health workers in the very first group, and then with several other groups right behind them. I certainly hope that we see people experiencing homelessness placed very high up in that prioritization scheme. I also think, though, that we need to be extremely thoughtful on how we do this. This is a vaccine that actually it's almost certainly going to need a series of 2 vaccines to be effective. It's a vaccine that will have some side effects that could very easily scare people. And I think we need to realize that the healthcare system has not really engendered trust from the communities most at risk for homelessness. And there could be reason for people to be quite frightened of the vaccine. So I think it presents 3 issues. One is, how will people who experience homelessness be placed in the prioritization scheme? I think that is still being discussed. I think because of the very high risk of congregate settings, for people who are going to be in shelters, it seems like they should be at the very top of the list. I would argue that people who are in unsheltered settings where they seem to be at lower risk of acquisition of COVID, for other reasons, should be near the top of the list as well. I think it creates a pragmatic issue of how we do this vaccination. And I, really hope that each state, as they are determining their vaccination strategy, that they are engaging people with expertise in homelessness. And by expertise, I mean people with lived expertise of homelessness, as well as those who work with them, to think of how we are going to come up with a strategy to effectively bring vaccines to this population and to support the population through this extremely important initiative. We have been doing a fair amount of work talking to people experiencing homelessness about their willingness to get vaccinated and their concerns about it. We're seeing relatively high acceptance of vaccination, although many of the same concerns as we would expect to see. And as I said before, I think that we need to not only prioritize this population, but be smart about how we reach this population. It's going to be a very difficult problem logistically, but I think it's a problem that really needs to be solved by those closest to the problem.
Thank you. Our last question is, what do you see coming from the Biden administration in the first few months?
Yeah, I think a lot, to be honest, is going to depend on the outcome of the upcoming Senate races and whether there, we can get Senate buy-in for some of these things. I see a commitment to, on day one, extending eviction moratoria. The Biden administration has put out a very exciting housing platform, including, fully funding for vouchers. Whether that happens or not, I think really depends on the Senate. I think that we desperately, desperately need COVID-related rent relief and economic relief. And I think that's going to be extraordinarily important. I think it's really a time, what we have seen time and time again with homelessness is that when there is actually a federal commitment to it, we see success. You see that in the Veterans Administration, where veteran homelessness has decreased year over year as there's been sustained funding and a reliance on evidence-based practices. I think that with the Biden administration, I have some hope that those practices will be taken up again. Housing first, fully funding vouchers, supporting the creation and, the production, the preservation, and the protection of extremely low-income housing. I think that we need economic relief, and I think we need to be creative about how we, get healthcare to those who most need it as well. So I am certainly hopeful, but I think a lot will actually depend on whether the Senate is willing to go along. I think there are some things that the Biden administration can do on day one, no matter what the Senate says or does. And I think we will see, for instance, an immediate action on things like eviction moratorium. Eviction moratorium are good, but what's a lot better is if we can get rent relief to go with it. And I think that is yet to be seen, whether they can get that passed through Congress.
Great. Well, thank you so much for sharing your knowledge with us today and answering these questions.
Great. Thank you for having me.
Whether you are recovering from an injury or illness or looking for support and guidance to live a healthier life, Samaritan Health Services wants to be a part of your journey. Together, we can achieve wellness, strength, hope, and joy. Find inspiration to live your best life in stories of triumph, resilience, and determination at samhealth.org/together. Samaritan Health Services, building healthier communities together.
If you remember one thing today, remember this. You matter. And because you matter, the world is better when you're healthy. That's why Care Oregon helps our members get the care they need from the Oregon Health Plan. And lots of good things beyond health care. When you're stronger, you make everyone around you stronger too. That's the Care Oregon effect. Learn how to apply at careoregon.org/OHP.
It's very hard for people to take care of their mental health needs, physical needs, if all you're doing every day is trying to find a safe place to sleep. We're all in this together. And the struggles that some people have, that could be anybody. That could be, me in 2 years. I don't know.
The state of mental health in the country right now is very, very challenging. There's enormous need from many individuals, and oftentimes there's limited ability to access or receive those services.
Historically, whole health care has been, you've got your primary care provider, you've got your mental health provider, you've got maybe your addiction specialists, and they're all sort of doing their own thing independently with very little communication amongst them. But whole health care for us now at Cascadia is that we're bringing all these entities together under one roof. And that's really exciting because now I get to work for a team of diverse professionals with various skill sets, knowledge, experiences, and we get to all put our brains together to really work on finding the best solutions for patients and getting the best outcomes.
So if we can address health from the behavioral health perspective first and foremost, and then add on substance use treatment, physical health treatment, housing, employment, social factors, wellness, you put all of those together, and that really wraps around someone creating a sense of whole health. So we've followed 900 individuals who have received behavioral health services who also are enrolled in our primary care as well. We found that over 80% of those individuals had not seen a primary care doctor in over 2.5 years. Over a year and a half time, we found that we reduced their utilization of the emergency department by 18% and their inpatient medical admissions by 23%. I have never seen results like that in my career, and it is a testament to an approach that can work really well to improve people's lives. It would be ideal to have more centers like the Garlington Center, a space where people feel comfortable, both clients and our colleagues, a space that is respectful and safe, and a space that promotes this approach of providing whole health care where individuals can get a variety of services that they need to improve the quality of their lives. And I could not be more excited for the creation of Garlington because it creates the first step towards a model of care that hopefully we can deliver here in Portland. We always must have support from our community in order to create these centers that really serve many important goals in our community. So we really rely on the generosity of our donors to achieve that, and we're so grateful that people believe in the work we're doing and stand with us in helping us move that forward and create places like Garlington.
For over 40 years, Central City Concern has helped thousands of people to find homes, to regain health and recovery, and to build economic stability and resilience. Every year, CCC works with over 13,000 people across several domains. We provide health care, inclusive of primary care, addictions care, mental health, that is really person-centered. We provide supportive employment, walking alongside people to help them get meaningful wage jobs. And we work with people to find housing that is safe and supportive and affordable.
I went from homelessness to homeowner in a matter of 10 years. I feel, my story does help others believe that they can do it too, because I did it and I didn't think I could do it. Some people have never had a job, or maybe it's been a very long time, and so we are able to offer more compassion and coaching, getting people ready to get into a more permanent full-time position.
Because of CCC, I was able to get my prison sentence suspended because they see me out here working and cleaning up the town. I'm 36 years old, been in recovery for 19 months and 9 days. Got 5 kids at home. CCC actually helped me change my life because I got a job that I'm able to work with the background that I have, and I'm able to feed my children, and got a nice place to live, roof over my head. The people here at CCC are like family to me, especially my bosses, and they help me out with my recovery.
CCC has all the resources, the tools to get your life back in order. My name is Ralph Fakoko Tase. I was born and raised in Samoa. I didn't really think about recovery because I try to get clean on my own. When you're talking to yourself, when you're trying to do it by yourself and you're trying to do it alone, it never works. I would be nowhere where I'm at without the support and the programs that CC has. I'm talking about from Hooper to the recovery program, treatment, the medical field as well. I FaceTime my son every Saturday now. For a very long time, that wasn't an option. I value things today. There's so much value in my life. If I can do this, anybody can.
The impact CCC has is outstanding. The patients and the clients we can reach to, the things we can help provide to them, I think they come in not knowing what we can really do for them, and then when we're able to show them that, I think they're just beyond grateful. Our care teams provide a lot. A patient can come in and just as simple as just have a checkup, but if a patient comes in that's homeless, they need more medications because theirs got stolen or their IDs have been stolen. We definitely go above and beyond and go out of our way to try to find them the resources that they need.
We're each a piece of this puzzle. We're all equal and we all have a place. When we're all in this together, we create one beautiful CCC picture.
Thank you, CCC, for all the advantages that you guys gave me and helped me out. I got integrity in my work just because of that.
Thank you, Central City Concern, and all the mentors that helped me along my way to become a better person.
And thank you to Central City Concern.
Faftai Lava CCC.
Hi, I'm Dan Field, Executive Director of Community Health and External Affairs at Kaiser Permanente Northwest.
Hola, I'm Rocio Acosta, and I'm a bilingual engagement specialist with Kaiser Permanente.
Hello, I'm Tracy Dan Grace, Director of Community Health at Kaiser Permanente.
Hi, I'm Aaron Waters, and I'm an Equity, Inclusion, and Diversity Consultant for Kaiser Permanente.
Hello there, I'm Ron Scholes, and I manage the Northwest Employee Community Engagement Initiatives.
We're sorry we can't be together in person.
But we applaud you in your efforts in working in innovative ways to serve our community members in need of vital services.
Congratulations on your accomplishments.
And thank you for all you're doing to support our most vulnerable community members in this unprecedented time.
We miss being able to gather together
and celebrate the great work you're doing in the communities where we live, work, learn, and play.
But we are navigating these uncertain times together.
And together we will become better equipped for a new normal.
We are resilient.
We will persevere.
And and we will once again thrive.
Nearly 1 in 5 U.S. adults currently lives with a diagnosable mental health condition. Yet the dominant treatment model is still one size fits all, focusing mostly on people's symptoms rather than their needs, goals, and dreams. We believe everyone deserves to participate in the community without stigma or fear, to have a safe place to live, hold steady employment, and to build lasting friendships. We're here to create a new narrative for mental health, to move away from treating mental health conditions as problems that need fixing and toward a model that embraces what you want out of life. We are New Narrative. Originally founded as Lukedorf, New Narrative has been serving the Portland metro area for over 40 years. Our first site opened with the guiding thought that hope, compassion, and community were the key to mental wellness. We have since grown from a single site to an agency made up of outpatient clinics, residential treatment, peer programs, a transitional age youth program, supportive, transitional, and independent housing, homeless outreach, and housing navigation. We still believe that hope, compassion, and community are the keys to mental wellness, but we also know there are many ways to get there. We believe achieving meaningful impact requires us to think differently, see differently, and work differently. We are intentionally working to change a system that identifies people by their diagnosis into a system that values the person. A system that understands a diagnosis is something a person experiences, but isn't who they are. We're here to change the narrative on mental health services, to retire the term mental illness and focus on mental wellness, to stop containing and start embracing, to ensure that people seeking services can find a safe place to live, hold steady employment, and build lasting relationships. We believe the health of a community comes from the visibility of its people. We all deserve to be heard, seen, and recognized. It's your story. Live it your way.
Hello, Governor Kate Brown here. Welcome to the 2020 Oregon Housing Conference. I want to thank you for your dedication and determination to serving the people of Oregon, especially during these challenging times. Here's what we know. Housing is a human need, period. That's even more the case during a worldwide pandemic where physical distancing, isolation, and quarantine are critical to public health and staying safe. On top of that, stability, financial, emotional, and physical, is tied to our homes, especially for Oregonians struggling with mental health and substance use. We also know that Oregon has been experiencing an ongoing crisis around access to mental health and substance use treatment across the entire state. Only 45% of Oregonians with serious mental illness and 11% of people struggling with addictions receive the treatment they need each year. Last year, I signed a bill that dedicated $50 million to developing a stronger system of care through suicide prevention, substance misuse programs, foster care, behavioral health services, and capacity for behavioral health homes. I also established the Governor's Behavioral Health Advisory Council to move us toward a behavioral health system that is simple to access, responsive to who people are and what they need, and that leads to meaningful improvements in their lives. In my 10 years as governor, we've invested over $500 million in housing. To give you some perspective, this 4-year investment is more than we've invested in the past entire 162 years of statehood. But it's not enough. We must do more to address the housing and behavioral health crises together by providing housing people can afford, coupled with wraparound services that people need to thrive. Every Oregonian should have a warm, safe, dry, affordable, and accessible place to call home. We have work to do, but I know that together we are up to the challenge. Have a great conference and stay safe out there.
I'm Molly Harbarger. I was a reporter at the Oregonian when the pandemic started. At the time, I covered homelessness for the past 4 or 5 years there. I'm now the editor of Project Homeless, which is a grant-funded team at the Seattle Times focused on homelessness and poverty issues. And I am joined by Anna Patrick, who will be helping me out with this presentation. She's the engagement editor at Project Homelessness.
Alrighty.
So,
yep,
go for it.
Okay. So for our first question, I was hoping you could talk about, Molly, what it was like in Portland at the start of the coronavirus crisis, and what approach did the city take when it came to protecting its homeless population from this new virus?
Yeah, I had actually just returned from 2 weeks in Japan as coronavirus cases in Washington state began to increase in earnest. Shortly after that, it became more serious in Oregon as well. I had been asked to quarantine at home for a few days after returning from my trip. So I had only been in the office for about a week when Oregon's Governor Kate Brown shut down the state. At the time, she never said the word homeless. That week when the restrictions first went into place, or for several after, in Portland, it was clear that the pandemic planning for people in shelters was lagging behind that of housed people, and planning for people who were living outside was lagging even behind that. As I started reporting on it and inquired what would be done for hygiene, social distancing, those other kind of precautions, I remembered that I had visited Multnomah County, which is the county that Portland is in, their main headquarters, shortly before I left for Japan for an interview. And as we walked into a conference room, we passed another room full of high-profile public health officials and elected officials and different kind of people, high-profile people with seats at the table. But the Joint Office of Homeless Services was not there. He was meeting with us, even though this was a coronavirus-related meeting. And I mentioned that to say that clearly people without housing, permanent housing, did not originally have a seat at this table. However, the Joint Office of Homeless Services, which is the kind of local authority that distributes funding from the city and county and sets homelessness policy with input from both of those bodies, pulled together a plan pretty quickly afterward. First, they sent social distancing guidelines to shelter operators. Then a week later announced that they would open hundreds of shelter beds to make social distancing easier. However, they didn't have the hundreds of beds secured yet. So the shelters opened over the next few days, and some for several weeks in empty community centers, the Oregon Convention Center, hotels, that kind of place.
Alrighty. Yeah, now can we jump to going a little bit deeper into what was the shelter plan for Portland and what did it look like? How did it work?
Yeah, so they worked with what appeared to be very reluctant entities. The City Parks Bureau kind of reluctantly allowed empty community centers to be used. I heard from hotels near the Oregon Convention Center, including Metro, the body that owns the convention center itself, really wanting to restrict what photos were used and how the homeless shelter there was characterized, because it was clear that the Joint Office was having a hard time getting people on board, even in the midst of this global emergency, to allow homeless people to be in those spaces. However, they did get them open. And I got an insight into one of them. I was there for the creation of the convention center shelter to kind of observe how they were setting up the space to reduce transmission. I believe most of the shelters were similar in that they used curtains to separate cots and required people to sleep head to foot from cot to cot so that no one's head faced another person's. They removed chairs from eating and lounging spaces to reduce how many people could use that space at once and how many chairs were at each table. Of course, I don't know how strictly that was enforced once people were actually using those spaces. Most of these were operated under the same low barrier guidelines as pretty much all publicly funded shelters in Portland. And most of these shelters, actually all of these shelters, were just places to move people who were already in shelters. So these were not people they were taking from the street and putting into shelter. They were just moving them from one congregate shelter to these newer temporary spaces. So they were people who had already met those guidelines. In fact, it wasn't until the last few months in Portland that new shelter bed spaces were created as an additional to what existed when the pandemic started. And that was largely because of the mayor's reelection campaign rather than concerns about people living outside during COVID. After opening a bunch of general shelters, the county then opened some motels for people who were unsheltered or in shelter who were either sick or at risk of being severely affected by COVID, people with respiratory issues or who were older, that kind of thing.
I just want to throw in one, this is an off the wall question, just to piggyback off of what you were talking about though, Molly, was the new measures that you saw being put into place, did it feel like it was an improvement to where folks were coming from? And did it feel like it was in the name of, like safety or just like, I'm just curious.
Yeah. In terms of safety, I think that what the Joint Office and the city and county were trying to do was in the name of safety and has largely been effective. We haven't really had large outbreaks in shelters. We have actually had very little transmission at all among homeless people. And I think that we now have some science that shows that putting people into motel rooms, hotel rooms at least, has been a positive for their ability to access services and move on to more permanent housing. However, at the beginning, we didn't know that, of course. However, it did raise this question of Oregon is behind in shelters throughout the state. And as in many places, when travel was restricted, motels, hotels were hard hit. And so it did really jumpstart this conversation about what we should be doing for homeless people in the first place. Should, if this was always an option, is a dollar spent on that hotel room better than a dollar spent on a congregate shelter?
Great. So now I want to talk about the strategies for addressing and helping and supporting people with behavioral health issues, or for folks who might not have as much access to traditional shelter for various reasons.
Yeah, people with severe addictions and mental illness were actually largely excluded from these shelters. I think that some officials would make the argument that because the shelters, the social distancing shelters, were essentially just moving people from congregate spaces into other spaces and not adding on, that the same rules apply. However, there was a lot of rhetoric about, especially around the for people with medical issues who are especially vulnerable. Someone with mental illness who maybe is going from the hospital, who would benefit from being in a shelter or even physically meet those qualifications, wouldn't necessarily be able to access that shelter because the severity of their mental illness would exclude them from that space. And that was never truly addressed. It was often said that, they were working on a solution for that, or they would try like hell not for that to not happen. And, it's a question of whether that was ever put to the test, but there were never spaces specifically for people who are struggling in the midst of an active addiction or mental health crisis to quarantine with services and supports. In fact, across the board, services for homeless people and, many people with addiction or mental illness was really narrowed. Oregon already is near the bottom of and in many metrics at the bottom for access for people with to access treatment to addiction, to access treatment to mental health services, and the restrictions of being able to not being able to see people or having those services kind of going into a social distance, work from home atmosphere really narrowed what is available. So on a good day, often being able to get behavioral health treatment requires that issue getting so bad that it requires hospitalization. And so when the main behavioral health hospital here restricted its intake, and then Providence and other hospitals that deal with both some inpatient but also outpatient service, when they had to limit interactions, it left a huge gap that was largely unfilled. Portland has a few long-standing dry shelters or programs that require sobriety. Some are publicly funded, but most are operated by religious organizations and don't use public funding. Those remained unchanged for the most part, other than that they had the same issues with intake that almost all shelters dealt with. Leading up to the summer, the city opened 3 outdoor tent sites. Each of those have about 30 to 35 tents each, and were fenced in spots of city land that had pallets and tents and places to put your stuff and requirements for staying there, and then were governed by the people who live there. It was the first city sanctioned format of doing those kind of tent communities. And they each had different priority populations. One was for people of color, one was for queer and trans people, and the third was more of a general population. Those were pushed for by some in the homeless advocacy community and some elected officials. However, there was quite a bit of pushback and criticism. The money could have been spent to expand hotel room capacity rather than having someone essentially remain unsheltered on the street. They could have been put in a hotel room. Or the groupings should have included a women's only site. In reality, the tent cities were hardly ever at capacity and appear to have a high rate of turnover. However, they maintain high support and now appear to be in the running for being expanded, especially as large encampments continue to grow around the city. However, that turnover, it's unclear whether people are leaving to go into permanent housing at high rates or if they're just being turned over.
I think that's a perfect transition to talk a little bit more about what the city of Portland did to support people who are unsheltered, people living outside throughout this crisis, and even still, right?
Yeah, as I mentioned, at the same time all of this was happening, the city ordered a stop to camp sweeps and camp cleanups per the CDC guidance that many cities have followed, at least on the West Coast. Portland's normal approach to cleanups and sweeps is a complaint-based system. So someone files a complaint or identifies a problem with a tent or an RV or a park, and then a person goes and takes that complaint, they go to that spot, and then they fill out a rubric based on what they see that kind of prioritizes urgency. And then if it threshold, that's that bar was essentially raised so high that I believe only one site had any workers at it before the county started opening up businesses again many months later. So there has been largely very little of that camp cleanup work that was very routine and was happening all over the city every day before. But once reopening started, that bar has been continuously lowered since then. And now we're at the point where there's talk about resuming those cleanups as normal before the pandemic happened. And part of that is because Portland, has often been criticized for allowing homeless people to camp pretty much anywhere. And so those encampments have grown bigger and bigger. And as people tend to not have to move, they stay put, and then they start communities. And people living there, according to my reporting, find that really useful because they can share resources at a time. There's fewer resources than ever. They don't have to keep moving around and worry about where they're going to sleep each night, or they can camp out near one of the few nonprofits that is open. But at the same time, it's caused a lot of anger and concern from the businesses and the housed residents that they're camping near. One of the kind of mitigating factors is that outreach work has also been reduced. For the first few weeks of the pandemic, teams of homeless people and low-income people who were organized by the street newspaper Street Roots canvassed homeless camps throughout the county to educate people about social distancing and best myths about coronavirus, and distribute hand sanitizer and like warm clothes and other kind of hygiene and the typical supplies. This was before masks were mandated, so they weren't giving out masks. But that effort was just kind of to get out the word to people who didn't necessarily have access to as much news. And then it was kind of cut off. The availability of free food was reduced to just a few places. And outreach workers who used to more actively distribute food to camps and people where they are switched to more of an open food pantry model so that they didn't have to expose their staff to as much risk, but it also relied on homeless people taking buses or other transportation to get there. Transit at the same time has been more fraught than usual for especially poor and homeless people, as bus drivers push for more and more strict safety requirements and also have more free rein to eject people they don't want riding. That can also disproportionately affect people who, appear to be in the midst of a mental health or substance use disorder issue. In terms of medical outreach, a volunteer group of doctors and nurses that formed before the pandemic has continued to do outreach. However, there are not formal mobile medical services other than existed prior to the pandemic. Portland still does not prioritize, they didn't before and they still don't prioritize offering COVID tests for homeless people or even people in shelter. You kind of have to, for a long time, you had to be sick or show symptoms, or you had to be able to get to a hospital or primary care provider. To my knowledge, outreach workers did not and still don't have access to testing kits. A few dozen mobile toilet and hand washing facilities were deployed at the beginning of the pandemic. In the last half of the year, that was increased to about 100. And that has largely been positive and made a big difference for a lot of people. However, there is still continuing issues with housed people who are near those toilets, wanting them to be moved or trying to close them or get rid of them. There are not publicly funded access to showers or other hygiene facilities, especially not indoors in Portland, and there never was, other than at established nonprofits. But a shower truck run by a nonprofit, Harbor of Hope, is often stationed near where people can still get hot meals. And so that has been a very frequented and welcome asset. Nonprofits in general have struggled to keep up with services and maintaining the same level and also making sure there's access to them. I wrote about domestic violence services, especially for people living outside, which have been reduced to the point of being almost non-existent if you don't already have a place to be inside. In a lot of places, as I mentioned, that have served hot meals have either closed, and so the ones that are still open have also had to pivot to providing clothes pantries and have water 24/7 when it was hot, and doing all these extra jobs because they're now the gathering place in a way that they didn't used to be. A day shelter might have been that place, but now everyone is on the sidewalk outside of Blanchet House. And then other places had to figure out how to find people in a safe way, which often means that unsheltered homeless people have just gotten lost in the system.
All right. Yeah, and so now, after talking about sort of these different aspects of the Portland's approach, I'm curious to get your thoughts on how you think homeless people in the city of Portland have fared under all of these strategies. Are they better or worse? Yeah.
You know, most of my reporting has showed that it wasn't really the disease that was hurting homeless people the most. Portland has had, as I mentioned, very low rates of transmission, both among unsheltered and sheltered people. I used Multnomah County's data tracking dashboard that's publicly available. And they disclose positive test results and rates among, they categorize it by both homeless people and non-homeless people, as well as racially, as well as like availability of other kind of services, PPE, that kind of thing. And according to those numbers, there is almost no transmission among people living outside, or wasn't for a very long time. And I think if we have had any outbreaks in shelters, they have been very small and very recent. However, when I interview people, the problems that they were facing before are more acute now. And I think that is the common thread that a lot of people find, is that COVID-19, if you have not personally gotten sick by it, exposes all the places that either your housing status or your race or your gender or anything about how you move through the world, how you earn money, that kind of thing. It exposes where those gaps are and where the services that existed before were falling short. And so for homeless people, I found it is the lack of services, at least in Portland, and places to go inside and rest and be out of the elements, especially now that we're running into, you know, the pandemic started in the rainy season, and we're into that now when it's cold. We already occasionally have hypothermia deaths in the homeless population. And now there are very few places to get out of the elements ever. So that has been one of the biggest issues that I have found in terms of how this has affected the day-to-day life of people. Homeless people also were already in competition for resources, essentially. You know, Portland and Multnomah County have invested more and more in homeless services each year, and yet the need seems to be the same or grow. And so now they are in even more competition for things like food and clothes with people who have lost their jobs or ran into new medical bills or whatever other effects the pandemic has caused, which is kind of a newer situation for a place that, you know, we have more people on the brink of homelessness, but we also have a growing economy all the time, and that has largely stopped. Multnomah County, Portland, and the state of Oregon all have eviction moratoriums, and they now all line up to the same period, and they've all extended their moratoriums and keep and it appears they will keep extending them. And they also created grace periods for repayment when the pandemic is over. However, there's no real plan in place for all the people who will never be able to make up a year's, maybe more, worth of lost rent once that moratorium is lifted. And the CARES Act funding, that the $1,200 that a lot of people got, if not more, in terms of unemployment, has missed a lot of poor and especially unsheltered people. You know, groups like Street Roots that I mentioned earlier, and some outreach workers tried pretty hard to sign up homeless people to get their $1,200. But even with that, I'm sure that tons of people didn't know or didn't have access to computers to sign up. And, you know, a lot of people are in this population are unable, at least in Portland, we have a growing senior citizen population on the street. We have growing numbers of people with disabilities. We have, you know, somewhere near 50% of people have behavioral health issues. And a lot of them, it can be, you know, debilitating to the point that they can't work. And so a lot of them were already outside of the job market. And so even with extra money added to unemployment checks, they weren't able to make the kind of cutoff to receive those unemployment checks in the first place. They didn't have jobs to lose. And if they did, they, you know, often didn't meet an income bar. So a lot of that federal funding that has maybe made marginal help for people at other income levels has been largely useless here. Local entities have, and the state of Oregon have provided no cash assistance to people on the street. And as far as I know, there is no plan to do that. So people are largely left with the few resources that are available at the time. There are some things that, you know, mitigate the cost of being homeless. Parking fines for RVs parked on the street have gone away. And it's hard to judge what the arrest rate is for homeless people right now. Prior to the pandemic, it was, as early as 2019, about 52% of all arrests in the city of Portland are of homeless people. The booking rate of homeless people has increased every year since 2017, when the Oregonian first analyzed that 52% was the rate of arrest. And so while that has held steady, booking rates have increased for homeless people. And so it's hard to say what has happened since the pandemic, especially because at the beginning, Portland police stopped going out to calls, or said that they did, unless it was like a life-threatening issue. And then the protests started, which, and then continued for the next, are still going on almost continuously. And so that kind of skews our statistics. A lot of the police in a protest, but there's also a lot more police presence. So it's hard to say what that end of finding and seeing homeless people looks like at this point. But we do know that the Multnomah County jails, the local jails, have reduced their population because of COVID, which likely will mean that people like who are picked up on criminal trespass 2 or lower level crimes are being released. And that might be a permanent change. Once the protest started, as I mentioned, a lot of the emphasis and attention and energy in the city shifted to that. It was such a big presence here, and we had the federal government come, and so our homelessness response largely was subsumed by what was going on in the street in a different capacity. It affected homeless people in some ways. You know, porta potties that were out in the protest zone were removed. You know, I reported on the protests, and there are many nights that I was running past people sleeping on the street. We're all tear gas like the rest of us, or in the midst of flashbangs, and it was certainly disruptive. And there were also large groups of people who would be in those same spaces where people usually sleep, and there was always a risk that, especially when we see those low rates of homelessness, of transmission among homeless people, it's a lot of public health officials attribute that to the fact that there wasn't much mixing between housed people who are maybe going to grocery stores, working at grocery stores, seeing people mixing with homeless people. And so there was concern that there would be kind of transmission that way, but we have not seen a lot of that so far.
I'm curious, after listening to you talk, Molly, is there something when it comes to addressing and serving people's needs who are homeless in Portland, and what that will look like moving forward, right, in a post-COVID future? I'm just curious, is there anything that keeps you up at night, or sort of like remaining questions that will, take time to be determined of like how this will really impact folks?
Yeah, I mean, I think that I have a lot of concern that, we talked about the eviction moratorium earlier, and that there's just not a lot of planning at this point for what that's going to look like. And I think it could be a pretty, a lot of experts, even elected officials, have recognized that it's going to be a big blow. We spend a lot more money in Portland in the past few years on things like rapid rehousing, trying to get people from the street into housing really quickly who seem like they would be able to sustain it once there. Culturally specific services, especially among the people who like qualify for rapid rehousing and those kind of services. And, you can spend all of that money and it's still not going to keep up with the fact that so many more people are going to need it. And what are you going to do when, you might have a lot of units come open, but even if people can move in those units that people are being evicted from, they're still not going to have the income to pay for it. And there just doesn't seem to be a lot of planning around that. So I think we're going to see a lot of conversation as people discuss what has worked well. Hotels, the state of Oregon is looking to buy a lot more motels and turn them into homeless shelter or permanent supportive housing. And those conversations are progressing locally and at a state level. And I think a lot of that conversation is already identified as like what we're going to take from the pandemic, but it's all the people who are going to newly enter homelessness and possibly stay there if there aren't good solutions for getting them out of it quickly. That I think is the big question that at least locally they haven't answered. Awesome. Thank you.
So much has happened since the beginning of this year that it takes quite a bit of searching to remember what it was like at the very beginning of the COVID-19 pandemic, when we knew that there was some sort of threat out there in the world, but we didn't really know how it would affect us here in Oregon. But that doesn't make those recollections any less vivid. And even with that uncertainty, or maybe because of it, Multnomah County was prudent enough to begin preparing for COVID-19 really early on, even before it had a name. Our county's public health division launched its initial response team on January 28th, just 1 week after the first positive case of the virus was recognized in the United States. And as circumstances would have it, it was just across the river in Washington. In the first few months of this year, there was a daily barrage of new information bombarding us about the virus, its health impacts, its symptoms and lethality, where it was spreading, and how it was transmitted. And yet, we still had so much to learn. Our public health leaders, like public health professionals across the country, were in the unenviable position of parsing the noise, identifying the facts, and figuring out what the risk was to our communities and what it would take to keep our residents safe. So here at Multnomah County, upon the advice of our public health team, we began confronting the possibility that the virus could and eventually would spread here in our own community. And as we learn more about COVID-19, sometimes the information was changing by the hour, it seemed. The outlines of the threat became sharper, and the possibility of the pandemic touching our community became more and more real. In those early days, as I continued to learn more about the virus, and more specifically about the types of precautions that lowered the chances of people becoming infected, my first thought was for the people in our community living without a home, outside or in our shelters. For most of our community, those precautions, wash your hands, stay indoors, keep 6 feet apart, those were simple steps to take. But for our unhoused neighbors living outside, they were logistical challenges or luxuries. Of course, as the county chair, my greatest concern is for the health and safety of all of our community members. But it was becoming clearer that the dangers of this looming viral pandemic were going to magnify existing inequities, and that the people living outside and without stable housing were poised to bear an unacceptable risk of harm. So from that point, the question that kept ringing in my mind as COVID-19 took over across our country was, how do we take care of our neighbors experiencing homelessness? That central question has been at the core of my agenda and my work since the day I was sworn in as a Multnomah County Commissioner in 2009. It's a deeply personal question for me and an essential question for our community. And it's one that has a lot of answers. Answers that reveal and define our community's values, answers that are questioned, criticized, or politicized, answers that at the end of the day can be the difference between life and death for people who don't have the safety of a permanent place to call home. Despite the countless nuances and complexities of this question, the first step toward building an answer is with the fundamental belief that housing is a human right. And then we work from there to figure out how to make that a reality. Soon enough, the possibility of finding COVID-19 in our community gave way to our first case. And as the pandemic began to spread little by little in our community, it became obvious that time was of the essence. Our community, especially the most vulnerable, couldn't afford for the county to respond tentatively or slowly. We had no choice but to be decisive. And I'm proud that Multnomah County responded quickly to care for people experiencing homelessness who are at heightened risk, not just for contracting the virus, but for the health impacts that make COVID-19 so dangerous. But because of the work that we've undertaken over the past 10 years, we didn't have to start from scratch. In fact, the only reason that we were able to act so swiftly and nimbly was because of the work that we've been doing for the last few years, trying to answer that central question. How do we take care of people experiencing homelessness? For 6 years, we built, tested, and strengthened the systems and tools we use to meet people where they're at, provide for their most immediate needs, and then give them the help that they need. We doubled our investments, and they paid off. And what we've built over the past few years laid a strong foundation for how we responded to make sure that we could care for our neighbors, and they are unmistakably, undeniably our neighbors during this once-in-a-lifetime pandemic. There are a lot of people out there who think that homelessness is a new or an emerging issue, and that the responses that they know about, be it homeless services agencies or local government programs, are even greener. But we know that couldn't be further from the truth. For as long as people in our community have struggled with poverty, mental illness, substance use disorders, involvement with the criminal justice system, broken family ties, marginalization and discrimination, it's known homelessness. And while homelessness isn't a new issue, we also can't deny that more people are vulnerable to the circumstances that lead to housing instability right now than at any time in recent history. And that's largely because the safety nets and the social agreements that have historically acted as backstops before someone reached the point of homelessness, affordable but safe housing, accessible treatment for mental health and substance use disorder, disability payments that kept up with the cost of living, these backstops have been steadily and slowly chipped away. The inequality gap that keeps widening into a chasm, and local economic boons that don't benefit the community evenly, and flagging wages have only worsened the severity of the crisis. By the late 2000s, what many refer to as New Portland was taking shape as the local economy thrived. But underlying that growth was also increasing inequality and heightened desperation among those whose boats weren't being lifted by the rising tide. Against the backdrop of rising condos and ballooning rents, the public conversation around homelessness became increasingly callous, framing the issue as one of a nuisance or a blight, rather than as an actual issue of our neighbors being locked out of housing and other services necessary for their health and safety. The way people collectively thought about homelessness was also informed by our government, where too few local leaders showed political appetite to engage in the hard work of making meaningful changes to the way we supported the community of people experiencing housing instability. Still, I want to tell you that there was a lot of work being done among community organizations, passionate advocates, people with lived experience, faith groups, businesses, and the government to meet the needs of vulnerable people. Our goals were similar, but we weren't aligned or coordinated. And that meant that a lot of opportunities to serve more neighbors more effectively and more efficiently were being missed. So to build upon the work that was in motion and to leverage it into something greater, we formed a Home for Everyone, creating for the first time a new aligned network of current and former participants, service providers, government, business leaders, and the faith community, all aligned toward a singular goal: to end homelessness. When we started that work, we didn't envision preparing for a pandemic, obviously, but the systems and partnerships that we've built put us in the best position to handle a crisis like this. And at the very heart of those systems is the City of Portland and Multnomah County's Joint Office of Homeless Services, the natural next step after a Home for Everyone. The Joint Office's work over the past 4 years has helped tens of thousands of people while showing the promise of shared priorities and coordination. And I would be remiss if I didn't take this moment to thank the staff at the Joint Office. The way in which each and every one of you have stepped up during the pandemic is nothing short of incredible. You have kept giving everything you have, and these are folks who will never accept that something is impossible when it comes to protecting our most vulnerable neighbors. I know that people look around and see the sheer number of people in crisis, and they wonder whether that partnership that I'm talking about has actually done any good. Well, let me tell you, it has. In 2015, the county and the city and our partners were supporting 6,000 people in housing on any given night. Last year, On any given night, we supported more than 12,000 people in housing. These are neighbors and community members who might otherwise be on our streets or hoping for a space in one of our shelters. But they're in housing now because of our support. Of course, it's nowhere near enough. And the fact that so many more people could find housing, even as our overall homelessness count has stayed flat, shows us just how strong the headwinds are. But it also shows us what can happen when we focus on the only thing that actually ends someone's homelessness: a home. And that is the answer to the question of how we take care of our neighbors experiencing homelessness. But of course, that answer is too tidy, because when we talk about connecting someone to a home, we're not just talking about an apartment that someone can afford. We're also talking about the support services that they need to stay in that apartment. People don't need to wait until they're ready for housing. It's the system that has to be ready to offer people the supports that they need, whether it's behavioral health treatment, job skills, training, or something as basic as childcare. Housing shouldn't be a reward for recovering from a struggle with substance use. It's what helps someone recover in the first place. And yet right now, while that work is underway, we also know that there are still thousands of people who can't afford a place of their own right now. But just because they can't afford a home doesn't mean that they don't deserve a safe, warm place out of the elements. A place where they can find community, where they can find hope, and where they can find a chance to get back into housing. So we've set to work these past few years, listening to people with lived experience and remaking and growing our shelter system at the same time. Since we declared a state of emergency in 2015, we've doubled the number of year-round beds that local government pays for, from just under 700 to now more than 1,400. Shockingly, those new beds were the first that this community had added in 10 years. But that really doesn't tell the whole story, because we didn't just add shelter. We've changed what shelter means. Our shelters now welcome people as they are, whether they're in recovery or not, and to get them the support they need once they come inside. And we've added them all across our community, not just in downtown. We are meeting and helping people where they are. And these new shelters are open 24 hours, so people don't have to leave in the early hours of the morning and wait in line at night to get back in. We've also embedded services like housing navigation and access to physical and behavioral health supports. And we got rid of some of the other barriers that also used to keep people from coming in. We now welcome people with their pets, their partners, and their personal belongings. We also added year-round shelter specifically for families, where each family can find quiet and calm in the privacy of their own room. Partnership also means that all of our systems can work better together without the silos that might have kept someone from the services that they need. I learned about a couple, Kenneth and Anna, who had lost their housing and they wanted to come into shelter, but they didn't want to have to split up to do it. And although their caseworker was from a service provider that worked with youth and young adults, he found them a spot at one of our new couples shelters. Once they had a safe place to be, several different providers came to help them. Kenneth and Anna sought out counseling. They took a renter education class. They pursued job training, and they worked to have their records expunged. And they worked to apply for supportive housing. With all of that support, they were able to leave shelter and go directly into an apartment of their own. And that's the outcome we want for every person who's in our shelter, every person on our streets, a safe, stable place to call home. A response that works the way it did for Kenneth and Anna is the kind of response that we've spent the last 6 years pursuing, which brings us back to the current moment. As the local public health authority and the state's largest social safety net provider, making sure that our most vulnerable community members were kept as safe as possible was exactly Multnomah County's role when the pandemic hit. The challenge, of course, was in quickly building an effective response to a disease that we were learning more about with each passing day. Luckily, Multnomah County has a truly top-notch public health team, including Dr. Jennifer Vines, who only recently had taken over the role as lead public health officer to guide our steps and protect people living outside.
So in those earliest days, we had limited testing and we were essentially flying blind. We knew the virus was here, that it spread easily through close personal contact, and that it was most serious for the elderly and those with poor underlying health. So the situation immediately laid bare the risk to community members living in shelters and on the streets. We have no vaccine for coronavirus at that time, and our understanding of the virus itself was still quickly emerging. We didn't know then how many people could have the virus and not show symptoms, or how easily it could spread through basic human actions like talking in close proximity or singing. We were looking for lessons from other large cities, but as far as I could tell, we were all in the same boat. There was no playbook for this virus. So we had to go back to the basics of public health, separate sick from well, and give extra protection to those known to be at higher risk of severe illness. That meant spacing people out in shelters, screening for symptoms, setting up a place to safely put people with symptoms, and gearing up to get those at highest risk quickly into their own private housing. We didn't know then that masks worked really well to lower the risk of transmission, and more importantly, they were in short supply and reserved for people with symptoms and healthcare workers who at the time were expecting a wave of severely ill people.
So in consultation with Dr. Vines, our epidemiologists, and our communicable disease team, the county immediately got to work adjusting the way our shelters looked and operated, creating ways that would minimize the risk of a shelter outbreak just as much as possible. Before COVID-19, we already had experience in activating shelters during emergencies because every winter we call into action our severe weather shelters and outreach efforts to move quickly to make sure that people are safe from the worst conditions of the year. We started making progress within a single day, and within a matter of weeks, we had developed an evolving COVID-19 response to help people experiencing homelessness find safety in our shelters, and to the furthest extent possible, safety for those out on the street. That started with some fundamental steps. We knew we had to create physical distancing in our shelter system, and we knew that we had to provide personal protective equipment, PPE, and basic public health guidance to providers, volunteers, and especially to thousands of people in our shelters and sleeping outside. Immediately, we started moving people in shelters with respiratory symptoms away from people who didn't have those symptoms. We worked with our trusted community partners, Transition Projects, Do Good Multnomah, and Human Solutions to supply face coverings and to create new guidelines around cleaning, staffing, and other protective steps. At the same time, we spent days working with outreach providers and volunteers like Portland Street Medicine and Street Roots to blanket the county, bringing protective gear and COVID-19 information cards to people living without shelter. But we also knew from the very start that none of this would be enough. So we kept listening to our health experts and we kept pushing. And in just a few more weeks, we added proper space for physical distancing throughout our shelter system. We moved hundreds of people from our original shelter system and even from some community rent spaces, like Right to Dream 2, into 4 public buildings that had been left empty by the pandemic: the Oregon Convention Center and 3 community centers owned by Portland Parks and Recreation. At the same time, day spaces were closing, meal supports were lacking, and the providers who were able to safely stay open found themselves overwhelmed with demand. So we worked closely with Catholic Charities of Oregon and the Blanchet House to help fund thousands of meals a week. The Joint Office's Winter Supply Center, located in downtown Portland, turned into an all-year COVID supply center for outreach teams, for community organizations, and for volunteers. And it's still distributing resources to people living outside to this day. The city and the Joint Office worked with advocates from Street Roots and others to create 3 outdoor emergency campsites. And our partners at the City of Portland placed portable bathrooms and toilets near places where people camp all throughout our community. But that was still just the immediate and initial push. Inevitably, we knew that there would be people seeking shelter who had coughs and fevers. Remember, this was still late winter, flu season, on the way to spring and allergy season. And we also knew, by the very nature of homelessness and who it hurts disproportionately, that we also had to protect those who would be most likely to become severely ill and even die from COVID if they got infected. People with underlying health conditions, senior citizens, people from disproportionately affected communities of color. We had to take extra precautions in order to keep them safe. So over the spring and summer, in consultation with our public health experts, we explored adding 2 kinds of spaces: physical distancing motel shelters for those who are most vulnerable to COVID-19 but don't have any symptoms, and voluntary isolation motels for those in shelters or campsites, or even people in crowded family living situations who have symptoms and need a safe place to isolate and obtain testing with health supports on site. So we put out a call to the community. We asked motel operators to partner with us to provide individual rooms for vulnerable people. And they came through. The Jupiter Hotel called my staff before we actually called them. And in March, they hosted the first of our 2 isolation motels. And by June, we opened the first of our 5 physical distancing motel shelters. Thanks to those spaces, we were able to leave the convention center and our community centers and offer better protection, along with the usual suite of housing and health supports offered in our shelters, to nearly 300 vulnerable people who needed a safer place to be than in a congregate living setting. That was a huge lift. And I want to make something clear. Because of that work, we avoided losing a single shelter bed that we had before the pandemic, even as we followed the physical distancing guidelines that we were given to keep people safe. I couldn't imagine what it'd have been like if we hadn't done that work, if we had had to turn hundreds of people out of our shelters, away from our services and stability, and back onto the streets. That would have been a tragedy. And I wasn't going to let that happen. It's a testament to our preparedness, to our practices, to some luck, and to the flexibility that we've shown to keep following the science, even as the science evolves.
As of this moment, we have not identified a large outbreak in a shelter or campsite setting. I believe our early efforts have helped us get this far. That said, we are moving into a time of rapid virus spread and have to be cautious as we move into the winter months and the reality of COVID fatigue among so many who've been working so hard for the last 10 months. Working in our favor are our incredible partnerships and compassion of our county staff. Unfortunately, spread of infections among our unhoused neighbors is not new. Public health has a long history of working with individuals with infectious tuberculosis, housing them until they're no longer infectious, doing contact tracing, and supporting them to get through months of antibiotic treatment. When the pandemic started, our communicable disease and sexually transmitted disease teams were deep into a response addressing an increase in HIV, syphilis, and Shigella among marginalized community members, many of whom did not have stable housing. We need to continue this full set of efforts and find ways to boost them in order to get through these colder months with all of our communities intact.
All of the work that we've done, all of the work we're doing at this moment, and how we're preparing for the duration of this pandemic is impossible for the Joint Office of Homeless Services to do alone. Over the years, the Joint Office has built relationship after relationship to respond as a community to the basic needs of people experiencing homelessness. This partnership includes service providers, treatment providers, affordable housing developers, health clinics, restaurants, religious organizations, neighborhood associations, and volunteer groups. And all along the way, A Home for Everyone and the Joint Office have made sure that all of these partners knew that they had a seat around this really big table. This deep bench of partners is an essential pillar of our homelessness response, alongside other things like our facilities and severe weather protocols. When emergencies like cold weather and the pandemic threaten the health and safety of people living outside, we don't have to use precious time to find those who are willing and able to help. We know exactly who we can call. And we have a really good idea of how each partner can contribute to the overall response. The shared understandings of the rhythms, the coordination, and the logistical nuances that we've built together over the years allowed us to hit the ground running. And that couldn't have been more critical as we trend on our response to COVID-19.
None of these efforts have been simple. Our Joint Office of Homeless Services has helped establish a direct line to community-based partners. As we developed public health strategies, we brought in those partners early to see what would work and what wouldn't. We had to test our assumptions against the realities of serving this population. That process has helped us to refine our response and realize that our role is not just to protect those living homeless, but to give confidence to those partners that we are doing everything we can to protect their staff and volunteers. For those living outside, we've offered a framework to the city about weighing not dispersing groups and potentially spreading the virus against more immediate health hazards like untreated human waste, uncapped syringes, and groups that make it difficult to allow at least 6 feet of distancing in public spaces. As I speak, many dedicated individuals are tackling the huge challenge of getting people inside on the coldest nights this winter, while at the same time minimizing risk of COVID spread.
The better our response to the crisis of homelessness, the better we're positioned to help vulnerable people during other crises. We are incredibly fortunate to have this infrastructure in place to keep people safe so far through the pandemic. And we also saw our preparedness pay off during the wildfire and toxic air events in September. We took the relationships that we'd built and deepened throughout COVID-19 to quickly open clean air shelters 9 days in a row, while also getting out more than 30,000 masks to people across the county. We also see so many other crises that overlap and play out on individual scales that without intervention trap them in homelessness. Their physical health, their involvement with the criminal legal system, unmanaged mental health challenges, untreated addiction. But the oppressive weight of each of these crises that keep people from finding stability, wellness, and opportunities to thrive can be lifted, at least in part, by access to housing. As we continue to provide shelter and connect people to the limited housing stock that we have, bringing more affordable and accessible housing into our community is the outstanding body of work that is still ahead of us. Just imagine what our pandemic response could have been like had we had the resources to invest even more in the ways that we care for our neighbors living outside. Or imagine if we had a meaningful inventory of affordable, supportive housing as this pandemic approached. Way back when the governor ordered our state to stay home, save lives, what home did our houseless neighbors have to stay in? This pandemic laid bare the costs of not having enough housing and support on hand for everyone in our community. As long as we don't have enough housing, even with a robust homelessness response infrastructure, and no matter how swiftly and nimbly we're able to react, we're going to be playing from behind to keep our neighbors safe and healthy. And as long as we don't have enough housing, and as long as our society is held up by systems with inherent inequities, we'll have to keep answering the question, how do we take care of our neighbors experiencing homelessness? The answer is to invest in the future that we want to see, to make sure people have a safe place to sleep, to build more affordable housing, to provide connections and relationships to guide people into housing, and to make sure they have the support they need to stay housed. The good news is that we've already begun that work, and the community is standing with us. 3 years ago, former Portland City Commissioner Nick Fish and I stood together and promised 2,000 more units of supportive housing by 2028, almost doubling the number that we had at the time. And I'm happy to say that we are well on our way to meeting that goal. And then came Here Together, and the ballot measure for supportive housing that voters overwhelmingly supported just this last May. These Here Together funds will also be used for our future Behavioral Health Resource Center, which will give people experiencing chronic homelessness downtown a single place to go to take care of their basic daily needs, to receive peer counseling and behavioral health and substance use treatment, and to find shelter and transitional housing too. That so many of us voted for this measure proves that our community understands that ensuring people have sustainable, supportive housing is the work we must all share. It's the work that I was committed to when I first entered county office, and it's the work I will keep doing until my last day as Multnomah County Chair. This is the work that we all have to keep doing before the pandemic, during the pandemic, and after the pandemic, until we don't have to ask that question anymore.
Hi, I'm Dan Field, Executive Director of Community Health and External Affairs at Kaiser Permanente Northwest.
Hola, I'm Rocio Acosta, and I'm a bilingual engagement specialist with Kaiser Permanente.
Hello, I'm Tracy Dan Grace, Director of Community Health at Kaiser Permanente.
Hi, I'm Aaron Waters, and I'm an Equity, Inclusion, and Diversity Consultant for Kaiser Permanente.
Hello there. I'm Ron Scholes, and I manage the Northwest Employee Community Engagement Initiatives.
We're sorry we can't be together in person.
We applaud you in your efforts in working in innovative ways to serve our community members in need of vital services.
Congratulations on your accomplishments.
And thank you for all you're doing to support our most vulnerable community members in this unprecedented time.
We miss being able to gather together
And celebrate the great work you're doing in the communities where we live, work, learn, and play.
But we are navigating these uncertain times together.
And together we will become better equipped for a new normal.
We are resilient.
We will persevere.
And we will once again thrive.
Gracias.
Nearly 1 in 5 U.S. adults currently lives with a diagnosable mental health condition. Yet the dominant treatment model is still one size fits all, focusing mostly on people's symptoms rather than their needs, goals, and dreams. We believe everyone deserves to participate in the community without stigma or fear, to have a safe place to live, hold steady employment, and to build lasting friendships. We're here to create a new narrative for mental health, to move away from treating mental health conditions as problems that need fixing and toward a model that embraces what you want out of life. We are New Narrative. Originally founded as Lukedorf, New Narrative has been serving the Portland metro area for over 40 years. Our first site opened with the guiding thought that hope, compassion, and community were the key to mental wellness. We have since grown from a single site to an agency made up of outpatient clinics, residential treatment, peer programs, a transitional age youth program, supportive, transitional, and independent housing, homeless outreach, and housing navigation. We still believe that hope, compassion, and community are the keys to mental wellness, but we also know there are many ways to get there. We believe achieving meaningful impact requires us to think differently, see differently, and work differently. We are intentionally working to change a system that identifies people by their diagnosis into a system that values the person. A system that understands a diagnosis is something a person experiences, but isn't who they are. We're here to change the narrative on mental health services, to retire the term mental illness and focus on mental wellness, to stop containing and start embracing, to ensure that people seeking services can find a safe place to live, hold steady employment, and build lasting relationships. We believe the health of a community comes from the visibility of its people. We all deserve to be heard, seen, and recognized. It's your story. Live it your way.
Whether you are recovering from an injury or illness or looking for support and guidance to live a healthier life, Samaritan Health Services wants to be a part of your journey. Together, we can achieve wellness, strength, hope, and joy. Find inspiration to live your best life in stories of triumph, resilience, and determination at samhealth.org/together. Samaritan Health Services, building healthier communities together.
If you remember one thing today, remember this. You matter. And because you matter, the world is better when you're healthy. That's why Care Oregon helps our members get the care they need from the Oregon Health Plan. And lots of good things beyond health care. When you're stronger, you make everyone around you stronger too. That's the Care Oregon effect. Learn how to apply at careoregon.org/OHP.
We have a crisis on our hands, living in our very own community. If we put this on an international stage, we have 4,000 to 6,000 people on any given night sleeping on the streets of Portland. And if this were in another country, they might all be in a camp served by the UN and on CNN every night. Hi, Portland Street Medicine. A couple of doctors out checking on folks. Anybody home? Instead, they're our neighbors. They're sleeping under our bridges and around our corners and in our doorways. And there's a tremendous degree of suffering, and there's an opportunity to step up and help.
No matter how many clinics you build, no matter how many hospitals you build, there's a portion of the homeless population that will not come indoor and access health care.
The reality is that there are no easy solutions here, and it's going to take a community-wide effort of us all pulling together. Portland Street Medicine is one piece to that. We're offering the health care, we're offering the direct outreach, we're building trust and continuity with a fragile and complicated population, with a goal of trying to build pathways towards integrated care, towards getting into clinics, towards housing.
So the nature of this work is very simple, and the goal that we have is achievable. Making house calls is not a new practice. It's been around forever. We're just doing it a little differently. It suits this population for sure.
I think what's really surprised me about working in the camps with the homeless population is how incredibly vibrant and caring and sensitive these communities are. They are neighbors just like you and I have at our homes. And getting to know the people, getting to understand the communities, having them refer each other to our care when they'll say, gosh, I'm fine, but I'm worried about the guy 2 tents down, really puts a very human face on the problem. People have been so warm and so welcoming on the streets. I can't begin to tell you how amazing it is to walk into a camp and from afar have people saying, hey, it's our street medicine team, they're back.
It makes me feel great because we've needed that for a long time. You guys are wonderful.
Hello again, I'm Jason Renaud, the coordinator of the Oregon Housing Conference, and now I'm with Drew Grabham, who's the leader of the Portland Street Medicine, a very exciting new outreach service. Drew, welcome.
Thank you very much.
Drew, tell me a little bit about how you got to this work, how you got to Portland Street Medicine.
Yeah, my journey began in Alaska in 1997, where I started working for a mental health center, and I quickly was allowed to go and walk around town and try to connect with people and get them engaged in services. And I sort of got the itch there and learned about it. And I moved to Portland in 2008 and started working at a local hospital in the ER and inpatient world. But I always had that itch to want to get back on the streets because that's where I really felt that healing and recovery happened. So I was fortunate enough in 2010 to get the opportunity to start doing some outreach as a paid job through OHSU here in Portland, Oregon. And I was able to start doing that work for about 8 or 9 years until I sat next to 2 doctors in a health and housing meeting that the county was running who were really interested in doing some outreach. And so I just said, like, I'll show you around. Let me take you around to do this. Cause I was kind of sick and tired. When I was by myself, my job would be to go find people and then try to bring them to services. And I realized, this would be a lot easier if I just brought the services to them. Right. Why can't I get a doctor to come out and just check out this wound? Why do they have to go through this whole hassle? I have the car. I'm the one with the privilege that can get there faster. So again, fortunately enough, 3 years ago, I was in the right place at the right time and met 2 doctors who were interested in doing this work. And 3 years ago, 2 docs, a nurse and a social worker, got in a Subaru in Portland, Oregon, and just said, like, let's just go start delivering care on the streets here. And we've been fortunate enough to be able to grow that practice of all volunteer teams to go out and serve about 1,600 unique individuals last year is what we served here in Portland on the streets.
Those sound like really unique individuals. What draws them to this sort of work? Most doctors would not even be at that county meeting, much less go out with you in a Subaru.
Yeah, what really brought them there, and I think they would share this too, is it was a part of their own wellness. It was a part of their journey where they were recognizing they were working in a system that had a lot of barriers, and they both were 2 ER physicians that were recognized that they didn't quite understand, why did people keep coming back to the ER? Why were there individuals that had high utilization that came there? And they were interested in doing that because they They wanted to feel like they were making a difference in people's lives. And that's the beautiful thing about what Portland Street Medicine does, is it provides wonderfully exceptional care for the individuals on the streets that we get to serve. But we intentionally created it so it helps address our own wellness as providers, and our own emotional distress. We often are the face of a broken system, telling somebody why we have to ration care, or why we may not be able to resolve all the issues, or be able to solve all of the problems that they present to us. And that can hurt us as human beings. Again, I know I got into this field to want to be a human-based helper for somebody. And I really wanted to get into a field where I could help empower people to be able to lift themselves up, to be able to get the resources that they need, and to work on the goals that they wanted to work on. And that's oftentimes what our traditional healthcare system doesn't allow us to practice like that. It has rules and conditions and time limits, so to speak, on what we can do with things. So street medicine really is created to help both the provider and the recipient of the services towards leading healthier, holistic lives.
So this is a movement growing all over the country. We've seen medical mobile services of many types and configurations start. Tell us a little bit about what medical mobile services are from your perspective.
Yeah, I think that's it. You're right. There are so many different models: paid staff, volunteer. Is it staffed by an EMT or an MD? And is it groups of teams and so forth? For Portland Street Medicine, how we organize our teams is a prescriber. So that could be an MD, that could be a nurse practitioner, that could be a PA, a nurse, a social service provider, which tends to be either LCSW. We have some wonderful community health workers, and a couple other like super caring resource specialists that know everything about all the services we would need to do, that go out in our teams, and we can really provide beautiful multidisciplinary care, like right in that moment. Like I will sometimes be holding somebody's foot while the doctor and the nurse are doing the wound care, while I'm talking with them about how to apply for disability benefits or things like that. And it's really this holistic picture of a whole human's life where you get to see the conditions they're living in. And then we get to sort of practice all of our specialty cares. And it really has this powerful impact on individuals that are currently living on the streets of Portland. We often get, part of the healing that we're trying to also do, I would say, is we often just say, hey, Portland Street Medicine, you guys need anything? You're doing okay? And we so many times get, no, I'm really good, but thank you for coming out, or thank you for doing this, and just thank you for seeing me. And I say, like, the least thing we can do is see someone and hear what they say and validate that, like, it's tough or that it doesn't seem fair. If we can just see, hear, and validate, we're already practicing medicine. We're already helping folks overcome the trauma of being houseless in Portland or houseless in the community that they live in.
Mm-hmm. I'm interested, I'm a mental health advocate and addiction advocate, but I'm always interested that that's not the first thing to talk about. That you're talking about their body, and that's a great doorway to then talk about their brain.
Right. And their feelings and their story and their history. And sometimes we get to flip it. They just tell us that. And it takes us we'll visit for a few times. They'll tell us a little bit about themselves. Then they'll say, hey, you want to check this thing out? And we're like, yes, we do. Please let us look at that. Right. We love to do that. But we really look at someone as a whole person in their living environment. So we know if somebody maybe is diabetic, on insulin, and storing their insulin in 95-degree heat out there, and we know, then we have a better understanding of some of the challenges they have and why they might come back into the hospital. Or just like when you're visiting and you're sitting in a camp with somebody, you'll see how they might care for themselves if they don't have clean water, or where they might go to the bathroom, anything like that. You can start to understand how that skin, the skin condition they have, or the abscess, isn't going to heal in that environment. So we give them the best chance that we can and the supplies that they need to hopefully overcome that. And part of what we're trying to do is also educate our existing health system to be able to understand really what it's like to be on the streets. One of the things I'm very proud of with street medicine, again, is we bring along our county commissioners, and other decision makers, we want to show them, can I please come with us? We want to show you how some of Portlanders are living and just recognize some of the challenges they have. And then we let them speak for themselves about why they've tried to, or how they've tried to access care and haven't been able to. And what I can say it all along, all along what the stories I hear, but to hear it straight from somebody who said, like, I went to the ER and I tried to do the follow-up and I couldn't get into that clinic, they said, or I had the wrong insurance, or I didn't have a phone. You really start to see the impact of this lack of resource that these patients have and why their engagement isn't, why there's even more greater barriers to engaging just in basic care for themselves.
We're today in a crisis. And these people are having a crisis inside of that crisis. Start by telling us a little bit about how COVID affected people who are homeless that you were reaching out to. But also, let's also talk about the fact that we had an enormous amount of smoke in the air here in Portland over the summer, maybe about 12 days, really unbreathable. I think it was 4 packs a day of smoking. If you were outdoors all the time, no one was outdoors. And then we had the George Floyd protests in downtown Portland. Concentrated area, but that's also an area shared by a lot of homeless people. That's where they live.
Yeah. So with street medicine, we didn't stop doing any of the outreach throughout COVID. We adjusted a little bit. We shrunk our teams down to a manageable, safe level. But when COVID first started, we actually just spent a month just educating people about what it is and what they could do, and sort of trying to validate that it was a real thing that they needed to be thinking about and understanding. So for the last 2 weeks of March, first 2 weeks of April, our teams were really just providing education. We created handouts about what COVID is and isn't, what they could do, and talking about those resources. And then as COVID evolved with there, we spent more time providing just education and screening for potential breathing problems. And then our job was to really help someone navigate towards a system where they could get tested if they were interested in getting tested, or the treatment that they were. And then a lot of what with street medicine, we've continued to sort of be involved with our county created some COVID motel places for folks while they're waiting for that testing, and we would be able to refer some folks into that motel. And then we did some follow-up if they leave the motel, if they were negative, of trying to get people connected into ongoing services if that's what they're interested in. Then when George Floyd was murdered and we had all of the protests in Portland, it had a significant impact on the population that we were serving. This was in a very small portion of downtown. It wasn't that wild. There was like the protests on TV made it be this big deal, but it did have this impact on folks on our streets. We took for about a month in July, we were taking care of a lot of wound care from rubber bullets and other things that our homeless population just sort of had secondarily, or they were sort of displaced by the protests and lost some of their medications. So again, in July, we were spending a lot of time doing skin care and other things with lots of welts and care there. And then beyond that, then we had the fires come on, and it was just the most unhealthy air you could imagine for a solid 2 weeks. And we were just basically delivering N95 masks and as many masks as we could, because there wasn't a lot of places for people to get respite from that air. My paid job is at a hospital. We were even struggling with talk about distress. You discharge somebody, but say like, now you have to leave, and you were sending them out into this harmful smoke. And so many people were just, so many providers were so distressed by that, and they should be. This shouldn't have been, this is no human should have been like, sorry, go out and breathe this air. I know we've got nothing else for you, but you need to go now. You need to leave. And so again, it just sort of like built up the stress of all of these things really built up. And you could see that in and I'm talking about the provider distress, right? As us as a community, trying to address bigger needs with even less resource that exists. One of the things that I would say as a system we saw here in Portland is that before COVID, there was a lot of outreach. There was less outreach. There was less people just trying to serve this population with greater needs of a significant health crisis, and then being displaced with all of the sort of feelings and emotions of the protests, and then the fires. Again, it took a profound impact. The teams that I support with my paid job and at Portland Street Medicine, we spent considerable time just debriefing that so that we could show up for work the next day. Because it had a profound impact of trying to do more with even less that existed in the community, and recognizing that there was going to be some long-term health effects greatly disproportionately affecting the community that's houseless in Portland. What I think I want to say, and I'd be remiss if I didn't say, like, in the last few months, so this is now November, I'm oriented, November, with street medicine, we've had a significant loss. We've had more people pass away these past few months, and that's what I see coming. I think the cumulative toll of all of these things coming up, we've had more loss, and we've had we almost have had like 1 or 2 people a week that we know have passed on, which is a higher percentage.
And these are not COVID deaths necessarily.
These are not related to COVID deaths necessarily. These are other preventable deaths. But I think it all had this impact on their ability to engage in services. And I just want to, I say that with a heavy heart because people are dying on the streets. Whether it's directly related to COVID or not, it was COVID impacted because they had less services to access.
And tell me a little bit about, let's not go into why, but tell me a little bit about the impact of services being cut: food, shelter, medicine. What happened?
Yeah, here in Portland, folks, we pivoted towards virtual visits, which is a wonderful part. Like, I like that we were able to create some new opportunities there, but one of the things you need for a virtual visit is a phone. And it has to be charged. And so that became a big challenge for our folks of, like, maybe we could get them a phone, but how would they keep it charged? Our day centers weren't open for them to be able to charge. So it became more complicated. It was a pretty significant pivot to navigate those systems there. Clinics are just now in November sort of returning to having some in-person visits, but even our urgent cares are, for street medicine, one of our two of our main like referral sources, like, hey, you could stop in here, are still not doing walk-ins anymore. It's all appointment based. When we know with this population that's not really serving them well. Folks had a harder time figuring out just basic things like, where am I going to eat? Where am I going to get clean water? Where am I going to go to the bathroom? How am I going to manage the refuse that's been created? And how do we sort of do that? And then folks were, when they're displaced now, it has an even greater impact on their health because they've been able to sort of cohort up, just like all of us have pods. Hey, we'll all try to distance a little bit. We sort of have these norms. And then when that gets disrupted, people's healths are impacted and they have to start all over again. Just having this other continuing compounding effect on their lives and on their health in that moment.
Well, chat about that a little bit. Tell me about the sweeps and what has been the effect of the sweeps in Portland. Portland didn't do any sweeps for several months and is now back full-time sweeping.
Yeah, I'd say that the population that we serve, that just gets to be a really big challenge of, like, can we locate them? People are back to kind of being worried about that, or being moved along. So they have a little bit less of a priority, and like, hey, let's get you that appointment in 7 days. Remember, we got to make the phone call to get you the appointment to be able to, get your medication refilled. That's so far in the future. They're just literally trying to figure out, like, where am I going to go to the bathroom now? Or how am I going to sort of survive in this moment? And I think that sort of greatly impacted our ability to sort of help folks engage in some of the care there. And it kind of compounds that trauma. Again, I think the thing I know about all the population we're serving is this is a very traumatized population. Like, just repeatedly on a daily basis, they're being traumatized, which we know just leads towards poor health outcomes and poor health engagement at times, which just, again, has like this compounding elevated effect on their lives that I think is why we're seeing, folks passing away earlier if they're living on the streets. 20 years, if you live chronically homeless, your life expectancy is like 47, much younger than everyone else. And I think we're going to continue to see that being ramped up with COVID through this year. And doing so, and then they have this complicated grief. I just want to also say that, so the communities that have lost loved ones, they have a complicated grief process. We all do with COVID. This is hard times for everyone. This, especially with this population where they maybe can't honor that human being, or they can't connect with the other communities as they did before to honor them and have that grief. I think that's going to have a profound impact on people's sort of mental health symptoms for years to come here, of like this sort of distrust and this understanding of not being able to have closure because they're just busy trying to survive. And I think I don't know if we're prepared to help adjust that need. Because again, I think that work is best done out directly face to face, not on a phone or not on a screen. I don't know how you could do that. And I think that's something we need to be really thinking about. How can we engage this population in some of that grief work that they're going to need to have?
Yeah, and we need a pastoral version, Portland Street Past. Let me ask you though, you mentioned long-term, it looks like the bourgeoisie might get access to the vaccine fairly soon, within the next 6 months. But the population that you see, do you think that they're probably in for another year or so?
It could be, it'll be really interesting to see how do we continue to ration that healthcare and how do we get them access to it, recognizing that they're a pretty vulnerable population as well. So I've not been in any of the specific conversations about how we sort of help connect this population. But I would say that we know that the population we're serving is very ill, usually by the time that we start to engage with them and have an even greater risk of having complications from COVID, or if not succumbing to COVID when they're there.
So sad. Thank you for your work, Drew.
Mm-hmm.
Thank you for your work, and thank you for presenting this session.
Yeah.
Any final words?
Yeah. I think let me think. What did I really want to say? I think the interesting thing that I think about with street medicine and all this is it's just a super great honor for us to be able to go out and meet this population and to really connect with them. And I just really encourage folks to just think more about how we can be creative. COVID has created some cool opportunities. We have been able to start doing a buprenorphine virtual visits with some folks, and that's a wonderful thing. So what are some of the positives we can take from COVID and some of the collaborations that we can take from there and make sure that we continue to have those things moving on into the future? Just like we've also recognized that if we didn't understand it before, housing is healthcare, and people's lack of housing does have a more profound impact on their healthcare. And I hope that we can continue to really continue to advocate for that and understand and truly see those in these times. These are very challenging times for individuals, and yet some of the most resilient people are the people that I get to care for and get to know and be a part of my community that are sleeping on the streets. They're wonderfully gifted individuals who often have so much more resilience than I have as a housed individual. And it's just a wonderful thing to see. And yet it's even harder when you see the profound suffering that they have. And that's that distress that I have. And that's ultimately what led me to spend my days off doing what I was paid to do as well, because it was just a part of who I am, to want to be a part of some kind of solution. And that's what street medicine taught me, is that even when it felt like it's overwhelming to change the system, well, I'm going to just start one life at a time, one step at a time. And hey, here we are. And I feel like we've made some great progress here, and I'm really honored to get to do that work. Every time I am in a street medicine meeting, I'm so thankful to be in that community. And every time I'm on the street, everyone has the biggest smile, because it is just really lovely, hard work that we have a dedicated crew that's just quite amazing. So if you haven't done outreach, please think about doing it. Reach out, try it. I guarantee it will touch part of your soul that will actually lead towards healing for yourself. So I think that's a good way. That's a good way for me to think about it. But I just encourage people to think outside the box. If COVID, we can do it. And when we do it, it does profoundly change you in this beautiful way as well.
Thank you, Drew. It is a spiritual journey.
The biggest fear I've had is not that the homeless community were more susceptible to this, but that as people sheltered in place and things shut down, we became more vulnerable because we lacked resources. Most people who have sheltered in place in their house, they're all focused on COVID when we're still focused just trying to live. It's been real hard surviving out there. Things are tough. I'm Raven Drake. I now live in Portland on the side of I-5 in a tent. I got here on a Greyhound bus. I served 3 combat tours with the 1st Marine Division as a Navy corpsman. This is the first time in my life I've ever been homeless. As the pandemic took hold and the stay-at-home order came in, places reduced their hours and some even ultimately just closed. Asking these people to stay in their tent and not move around unless it's essential is hard because survival is essential. And so we as a homeless population have tried to adapt. Life begins when small changes occur. It's a quote I'm very fond of. The original ideal started with a proposal to the city, and it was an outline for shelter-in-place camps. Right, Angel, you're such a cutie, yes you are. I'm so far ahead. We're so far ahead. My first concern was for my partner, who has an immunocompromised system. The healthier I could keep the people who would interact with her, the healthier I could keep her. So just try to kind of divide it between the two, because we got 2 camps we got to take this to. Yeah, like this is my baby. Like when this whole thing came, like this was the first camp we fought for. Right. We as a homeless population, the best way to combat this virus is to stay clean, is to be able to wash your hands, to take a shower, to have access to clean clothes. So we've watched those resources dwindle out here on the streets. Yep, it's all coming together. Yeah, we're making it work. I think these camps really are a starting point to something better, and that's my hope for them. But the biggest aspect for now is, at the very least, we can put 125 of the most at danger people into a camp and keep them somewhat safe.
We're not out here because of laziness or because of of addiction, and even if that were the case, it doesn't make us any less of a human being. The economy is already kind of rough, and the COVID-19 has put a lot more people out here. These camps can be a forever thing. I think they're the gateway to helping thousands of people who are out here on the streets. It'll help give them some kind of sense of hope, like there's somewhere they can go. It's a kickstart for solving a problem. Taking this place away from us after COVID-19, it'll just it'll make the streets go back to where they were again.
When this is over and people come back out and businesses reopen and people start hiring again, I hope they take notice of these houseless people who worked really hard through this to protect their community. Give them an opportunity to show that we are so much more than just somebody sitting on a street corner. We have stories and we have lives. When this is over, what do we have to do to start talking about permanent camps? This is not a sprint, it's a marathon.
Michaela. I moved to Portland a few years ago and I became homeless. As I was looking for ways to make money, I found Street Roots, and I felt that selling quality news to the community was a dignified way to earn money. But I got connected with Outside the Frame, who teaches youth to be the directors of their own films and lives. I quickly learned filmmaking was my passion. When the pandemic shut the city down, Street Roots wasn't able to sell their paper. I was worried how the vendors were going to get by. And I saw everything but desperate people in chaos. They were organizing a team to send out information and supplies to camps in the city, and it was all being led by a vendor, Raven.
Okay, so as you know, if you've watched the news, yesterday there was a large upswing in cases. That led the governor to start a stay at home, stay safe proclamation, which is just asking people, if it's not vital that you be out, to stay at home. Back in the beginning of January, I kind of watched what was happening up in Washington. And I'm a former combat corpsman with the 1st Marine Division. I served in Iraq on 3 combat tours, so I've always been medically inclined. Both of my campmates had a compromised immune systems, so this whole program, this whole ideal started as an outreach I was doing on my own for the first 4 weeks, just in the camps in my area, sort of to try to monitor people so that if somebody did get sick, I could take care of it before it got to my campmates. And then once we realized that the first cases had come in, so we just took the model I was already working and expanded it into a larger program and rolled it out virtually overnight. Since starting the program, our group alone has made it to every area of the city, and we've made contact with over 2,000 people and distributed supplies to them. I just have people who show up every day willing to go out to work.
With the action team out providing essentials and true information about the virus, Raven turned her attention to those needing safer shelter. She began writing proposals to the city for emergency shelter-in-place camps.
I actually do most of these planning sessions from my tent. It's my outdoor office, as it were. But I've been working with the city, creating a few permanent sweepless camps, someplace that can be theirs and can be permanent for as long as they need it. And so I think I really hate that this virus, and especially the deaths that have come with it, had to be the catalyst to open those conversations. But I'm glad that those conversations are finally opening.
After Raven had secured shelter for so many other people, it was time for her to find a more permanent shelter of her own.
So, this is my somewhat spacious kitchen.
Mm-hmm.
Better than the fire pit I had. This is Chris. This is all he gets, is just this little 6-inch area, and the rest of the closet's mine. And then, of course, my big trans pride flag, which, I came out as trans. And I came out here with the determination that I would start over and I'd be myself. All I wanted to do was show up in Portland and start my transition and be left alone. I just wanted peace and quiet. And I have done every single thing but peace and quiet. I had no idea that this is where it would go. I had no idea that this is who I was inside. I had no idea that I would do these things. But Kai asked me, do you want to work for Street Roots? And I told her I want to work at Street Roots more than anything, because that's my home.
I'm Tim Birch, the Human Services Administrator for Clark County, Nevada. I'd like to thank the Oregon Housing Conference for hosting myself and phase of working is through as I record this, where one landlord has 100 individuals that we're hoping we can adjudicate in mass and give one check out the door, and therefore be able to double up kind of the throughput of staff on a daily basis. So we are very hopeful around that process, and we're thankful to all of our partners and counties around the nation who were able to share some of their lessons learned with us. So we were able to be able to stand those programs up as well. Counties around the nation who were able to share some of their lessons learned with us. So we were able to be able to stand those programs up as well.